Well, good morning. It's 10 o'clock, so I think we will get started with the board meeting today. It's great to see everyone here with us today. Thank you. Just to start with apologies, we have had apologies this morning from Fiona Mitchell-Hill from Aberdeen, Chief Officer Aberdeen, but she is substituted today by Sandy Reid. So welcome, Sandy, and thanks for being able to join us. And we've also had an apology from June Barnard, but all board members are in attendance at the meeting at this moment. So thank you very much for all attending today. Thank you. Can I ask if there are any declarations of interest, please? Ian, please. Thank you.
Thanks, Alison. Just in relation to the Aberdeen IJB, I'm a member of Aberdeen City Council, which is NHS Grampian's partner in the Aberdeen IJB. Having considered the objective test, I don't believe it's necessary to withdraw. So just to confirm, this is a transparency statement.
Thank you very much, Ian. And Hussein, please. Sorry, Hussein, you're on mute.
Is that working now?
Yes, thank you.
Okay, thank you. Just to do due diligence and out of an overabundance of caution in relation to potential questioning on the how are we doing report, I may ask regarding a particular speciality for which I'm awaiting an outpatient appointment. So it was just to put that on the record out of due diligence. Thank you.
Thank you very much, Hussein. Thank you. And Kathleen, please.
Yeah, same as Ian. I'm obviously a councillor on Murray Council and have interest in the IJB, but I don't actually sit on the IJB, so it is just for transparency.
Thank you very much, Kathleen. And Anne, please.
The same here, Alison. I am a councillor at Aberdeenshire, although I'm not a member of the IJB, so I will continue. Thank you.
Thank you. And I'll make the same transparency statement as Anne's just made, being also a councillor in Aberdeenshire as well. So thank you very much for that. I can't see any other transparency statements anywhere. Thank you. Thank you for those statements, please. And then we'll move on then. And I will formally welcome you to the board meeting this morning. And we will start with some remarks from myself to the meeting. It's our final meeting, of course, for 2025, and we've had a very busy year and are looking forward to the year ahead as well. Today's agenda reflects the breadth and complexity of our work. We will receive reports from each of our integrated joint boards and the Grampian Area Partnership Forum, highlighting the importance of collaborative and partnership working as we move forward together. We will also hear a detailed update on the board's financial position up to October, along with the current year-end forecast. A separate IJB finance update is among the papers today, which helpfully describes the links between NHS Grampian and IJB finances, provides an overview of their own financial positions for 2025, and recognises the financial interconnectivity of our system. I want to highlight the improvement plan paper before us today, which proposes a new governance framework for greater accountability. Its content reflects the discussion held at our board seminar in November, and as we will hear later, it has a huge contribution to make to the delivery of our 3 priority programmes. I also believe it will aid us in our conversations with the Scottish Government's Assurance Board as we pursue the agreed criteria for de-escalation over the coming months. As we move into winter, I would like to recognise the work I have observed being undertaken with partners across the health and care system. A variety of measures intended to help alleviate winter pressures, especially in unscheduled care, have been developed and are being enhanced, including patient flow through emergency department, rapid assessment and discharge processes, and strengthened community-based support. However, it would be remiss of me not to recognise that winter has only just begun. The recent snow and icy conditions led to a marked increase in emergency department attendances due to slips and falls, and flu cases are on the rise, adding pressure to our services and indicating that significant challenges lie ahead. At this time, we ask that members of the public support our system through small but important actions, including collecting loved ones promptly when they are ready for discharge, taking up the offer of vaccinations, and avoiding unnecessary travel during severe weather. By working together, we can help ensure that care is provided in the right place for those that need it throughout the winter months. During my own recent visits to the allied health professionals working in the discharge hub and emergency department, I was deeply impressed by the team's multidisciplinary planning and focus on their own timely discharge processes. It was very useful to hear their ideas about potential improvements to the system. Their efforts are contributing to smoother flow through our hospitals, greater efficiency, and an improved patient experience. The hub's single point of referral for complex discharges, the upstream collaboration with the Flow Navigation Centre, GMED and SAS, Call Before You Convey, alongside pathway refinements, are also collectively reducing avoidable admissions and improving patient experience. My sincere thanks to every member of staff for turning pressure into progress. The board will continue to champion the resources, partnerships and transparency that sustain this work. I also want to recognise the child development team at Fraserburgh Hospital, whom I visited recently, and also their colleagues working from Aberdeen. I saw firsthand how their highly coordinated approach delivers integrated family-centred care, as well as their efforts to enhance their environment for local families. They truly embodied our commitment to putting people, and obviously in this case children, first. Colleagues who had undertaken the Quality Improvement Fellowship were the focal point of a recent board seminar. I and my board colleagues heard how quality improvement programmes are improving outcomes, staff and patient experience, and contributing to a high-performing culture across NHS Grampian. I was hugely impressed with how our frontline teams turned local challenges to opportunities for improvement through the application of a QI approach. I commend this work to the board and call on us all to champion it by encouraging the wider use of QI in innovation and decision making, enabling teams to test, measure and share improvements at pace and then apply them at scale. On behalf of the board, I would like to acknowledge the pioneering work underway, which is likely to see NHS Grampian become home to Scotland's first geothermal heating plant. Whilst there is much to do in order to translate this exciting feasibility study into action, I think it is an example of our resolve and commitment to sustainability. By harnessing clean, renewable energy, NHS Grampian can set a powerful example of environmental responsibility while ensuring long-term benefits for patients, staff and the wider region. We commend everyone involved for their vision and dedication. It is also with great pride that we recently announced the launch of the Swift Urological Response Evaluation, or SURE unit, a groundbreaking one-stop diagnostic centre for urological cancers. This has been made possible through the remarkable partnership between NHS Grampian, UCAN and Friends of Anchor. This ambitious initiative, supported by a generous £3.3 million contribution from our charity partners, will double our capacity to diagnose and treat prostate, bladder, kidney, testicular and penile cancers. The SURE unit will not only streamline the patient journey, reducing the need for multiple hospital visits to a single appointment, but will significantly shorten waiting times and improve outcomes for people across Grampian, Orkney and Shetland as well. Is a shining example of what we can achieve through collaboration. Finally, I would like to recognise the 40th anniversary of Grampian Hospital's Art Trust. Over 4 decades, the Grampian Hospital's Art Trust has brought colour, creativity and compassion into our hospitals, enriching the lives of patients, families and staff. From its beginnings with local artists and clinicians, its collection now spans thousands of artworks in more than 40 venues, showcasing the power of art to heal, unite and inspire. As we celebrate this milestone, I thank them for their unwavering commitment and look forward to many more years of partnership, creativity and positive impact. Thank you to them, to all the partners we're working with and to everyone who's contributed in any way to the work of NHS Grampian as well. Thank you. Okay, with that, we turn to the formal agenda and the minutes of the meeting of the 9th of October. Dennis, please.
Thank you, Chair, for letting me come in. Basically, it was just a comment you made regarding the trips and falls And I would just wonder if you're able to expand, and it may come out in other items in the agenda, expand about the collaborative work we're doing with our partners in terms of our council partners in trying to alleviate and identify the hotspots and to obviously mitigate against people attending A&E if we can actually address some of these areas within our 3 councils. Thank you, Chair. And I can echo the words that you've actually mentioned in terms of thanking all our staff for their undue commitment at this time as well. Thank you.
Thank you, Dennis. And I think can I bring Shantini in to talk about that work with partners on preventing slips and falls? Thank you, Shantini.
Okay, so this builds on some work that we did last year. So this is essentially using our data on trips and falls to identify where so when we have bad weather and ice on the roads and pavements, where those falls were occurring, and therefore then where we should be targeting gritting action and so on to when we have adverse weather to prevent some of this. So last year we trialed or did a test of change and piloted some activity where we gave funding to community groups in these affected areas, and so when we have adverse weather, these teams go out and grit the deal with the pavements, etc., to try and prevent trips and falls. That has evaluated well and showed that it made a difference. And this year, through the local resilience partnership teams and working groups, certainly in Aberdeen City Council, they've continued and were able to ensure that this intervention has continued, and so when we had the bad weather a few weeks ago, certainly those teams were out on the streets and working to clear the pavements and everything, and that's worked really well. So we're really delighted that we're able to continue to work in this way in partnership to try and prevent adverse health outcomes from trips and falls.
Yeah, thank you very much for that, Shantine. It's very helpful. It's being able to use data to target particular areas and work in collaboration with partners, like in that case, Aberdeen City Council, as you described, in order to make a difference. So thank you for allowing us to emphasise that point more, Dennis. Thank you. Okay, then we'll move on to the minutes of the meeting of the 9th of October. Can we approve the minutes, please? Thank you. Thank you. Minutes agreed for that one. And then we turn to item 4.1, the action tracker and matters arising. You can see the action tracker from the last meeting and comments about updates on that. The one I would like to pick up is the first one about the Operational Improvement Plan Performance Report, where a comment was made about how we understand how demand side meets performance in particular as well. And there was an example given around primary care, which raises the question about how we look at performance and demand in primary care at the board meetings. Sarah, could I ask you to comment about how we could take that item forward, because it's not mentioned in the update? Thank you.
Yes, we'll have discussions offline with the chief officers about how this board will receive updates from the new primary care programme board that's going to be put in place in the first quarter next year. There's work going on with stakeholder groups about the GP visioning work and the transition to implement some of those proposals that came to the board in 2024. So I'll pick that up with the chief officers, because the IJBs have the primary responsibility for getting assurance about the effectiveness of primary care, because that's delegated under the integration schemes. But obviously primary care performance has a big impact on secondary care demand. So I think it is appropriate for this board to see some information about primary care more regularly. So we'll take that offline and we'll update the board at the next meeting where we've got to.
Thank you very much, Sarah. That's helpful. Any other comments on the action tracker or any other matters arising? Colette, please.
Thank you, Chair. I just want to take this opportunity to raise the community appointment days, which are listed here under item 7.1. For those who haven't read the evaluation report, I strongly advise them to do so. This has been an excellent piece of work, and the results of the community appointment days are absolutely incredible. Alongside that, I just want to raise a note of caution. I've heard the IJBs mention community appointment days as part of the solution to health and social care in communities, and not for discussion now, obviously, but just to highlight the fact that the expectation is high and the resource is relatively small. But congratulations to the team on this first evaluation. It's been a really good piece of work, and I hope to see it continue.
Thank you very much, Colette, and a helpful comment there as well that can be followed up as well. Thank you. Mark, please.
Thanks so much, Chair. I think I'd echo Colette's comments there, and thank for the update to ACF as part of the action tracker. I think the third one is we may not quite get that done, Sarah, before Christmas, looking at timetables. So I'm happy to push that into January if you're comfortable to do so. Thank you.
Thank you for that. Thank you for that pragmatic response as well, Mark. Thank you for that. Okay, so that can be adjusted on the action tracker as well. Any other comments on the action tracker or matters arising, please? No. All right. Thank you. So we'll note that and move forward to item 5 on the agenda, which is the Chief Executive's report. And I'll turn to Laura, please. Laura.
Thank you, Chair, and good morning, everyone. It's good to see you all. I will take my paper as read and just pull out 2 or 3 key areas of focus, and then, of course, more than happy to open up to any questions or comments. So, firstly, much like the board chair's comments, I think as we reach the end of the calendar year, it's always a helpful opportunity to pause and reflect on the year that has just gone. And I think if we look at our 3 priority areas that I know we will touch on in more detail today, in 2 of those 3 priorities, we can evidence green shoots and progress. So with value and sustainability, we remain broadly on track with our financial and savings plan. And with planned care, notwithstanding the challenges that we've experienced as a result of the shutdown of our central decontamination unit, we can point to improvements there in terms of our longest wait patients, with a specific focus on 52 weeks and 104-week waits reducing. That said, we now need to see the same level of traction and results and delivery. If we look at unscheduled care, that remains a key area of focus as we go into the new year, recognising that our emergency patients deserve a better experience, which I know is what we all want to see. The 13th of November Cabinet Secretary announcement about the new statutory subnational planning and delivery arrangements for the NHS in Scotland are of such significance that they feature in a separate paper on today's agenda, which I will return to next on the agenda. Moving on to the Assurance Board, we continue to focus on the 3 priority areas, as I've just touched on, and I think it's fair to say unscheduled care continues to dominate much of that agenda, and rightly so at the moment, recognising we are an outlier if we look at our performance nationally. As the board chair said, as we looked at January's meeting, we will look at opportunities around de-escalation criteria and discussing what that might look like. And I look forward to discussing that with the full board in due course. And we know also, if we look at January's meeting, there will be a strengthened focus on culture, leadership and governance, which is much welcomed. And then finally, I want to recognise some of the successes of staff and celebrate a number of our achievements since the last board meeting, and in no particular order. Firstly, many congratulations to Wendy Harper for winning the support worker category at Scotland's Health Awards. Absolutely fantastic national achievement, and well done to Wendy. Secondly, Lisa Malcolmson and Rachel McBride, who have recently received the Queen's Nurse Awards. Again, absolutely fabulous achievement, and the board chair and myself have written letters of congratulations to all of these colleagues, and our medical paediatric team for the Paediatric Awards for training achievements. And last but not least by any means, the Grampian Hospital Radio for the King's Award, and this is the highest accolade colleagues can receive in the voluntary sector. So thank you to all of the volunteers who make the Grampian Hospital Radio possible. Chair, I will pause there, but more than happy to take any questions. Thank you.
Yeah, thank you very much, Laura. Thank you for that commentary on your update. I will turn to Dennis first, please. Dennis.
Yeah, good morning. Laura, thank you very much for that. And with reference to planned care, I just wonder if you maybe could expand on that a little in terms of how we're taking, what steps we're taking to mitigate some of the longest waits in partnership with some of our other health boards. So I'm just wondering if you could maybe expand on maybe some of the discussions that you have with some of your other chief execs in terms of accommodating some of our longest waiting people or patients for treatments. So for instance, at Golden Jubilee or NTS at Highland, and the impact that that's having. Thank you.
Thank you, Dennis. Laura, could you update, please?
Thank you. Yeah, of course. I think if we look at new outpatients, we can see real progress there in terms of over the last 6 months or so. If we look at 52-week waits, moving from circa 10,000 patients to now less than 5,000 patients, which is a significant step forward. And that has been possible as a result of multiple improvements, some internal, I think it's fair to say, Dennis, but also some through mutual aid support from our other health boards across Scotland, including the national treatment centres, including the Golden Jubilee, but also mutual aid from other boards who are offering NHS Grampian support. And what that means in effect is greater collaboration, more cross-board working, and quite a different approach, which really will link to the next agenda item in terms of subnational planning in many respects. And this is about where boards are on target in terms of their trajectories for 52-week waits, or indeed in some cases ahead of target. Those boards being willing to accept some deterioration in their performance to support boards such as Grampian, who are perhaps struggling in certain specialties, and we're seeing real benefits there from about 4 boards in particular who are supporting us in 3 or 4 specialties. And then finally, we're receiving support from the Scottish Government. We've received in excess of £11 million now in terms of planned care support, and that has enabled us to secure some additional independent sector support, in particular in urology and dermatology, where we know we've got waits that we wouldn't wish to see for our patients. So hopefully that's helpful, Dennis. Thanks.
Thank you very much. Thank you. Thank you. And see Dennis nodding. Mark, please.
Thank you very much, Chair. Thank you, Laura, for your report. Going back to the iMatter aspect of your report, and obviously this will be touched on in the paper later on, but I think we would like to welcome from an ACF and GAPF point of view the collaborative work that we've had going on recently in a number of meetings, and I think that's really important. Building on performance and leadership, I think is going to be absolutely essential as we move forward. And I note the inclusion of a culture programme board. I suppose from an area clinical forum point of view, we'd be happy to input if that's required, but I don't see that we've been necessarily invited as yet, but we would be obviously very keen to put that in from a clinical point of view if that was required. Thanks.
Thank you. To save Laura's voice on that, I think Philip's come in on that one, I think, Philip. And thank you for the comments about the ACF involvement, and collaboration with the ACF is absolutely essential as we move forward as well. So I appreciate those comments, Mark. Philip, please.
Thanks very much, Mark, and apologies from myself. At Chief Exec team earlier in the week, we looked at the draft terms of reference for the Culture Programme Board and highlighted an omission, which was the opportunity for Aerial Clinical Forum Chair to join us. So that invite will be coming out to you, Mark. So apologies from myself in terms of that omission. It's been recognised and you'll be receiving an invite. So thanks so much for flagging that up.
Brilliant. Thank you, Mark. And again, thank you for the work of the ACF. Derek, please.
Thank you, and thanks, Laura, for the report. I wanted to quickly talk about the Section 22 report. I thought that was very fair. When I read it, I thought it was a very fair report. And a number of interesting things coming out of it. I thought it does mention funding in a couple of places as a possibility for getting us out of our difficulties. It does talk about our bed base, and when you look at the numbers, 1.4 compared to the next best of 2, or the next worst of 2, that's very significant. And the thing that it missed, which I think would have been a big help to us, would have been the National Treatment Centre, which got postponed. But notwithstanding that, overall, I thought it was a very fair report and leaves an opportunity, I think, for much further discussion with Scottish Government on some of these issues. So I was very pleased to see it. Thank you.
Thank you. Laura, do you want to comment on that?
Yeah, thank you. A couple of points really. In terms of NRAC and funding, I think this is a national matter principally, but I think the subnational arrangements will actually bring those issues to the fore, which I very much welcome. In terms of bed-based, but I would actually prefer personally to describe this as system capacity moving forward. That may well be an argument we wish to make at the right moment, but as I've described to my senior colleagues in the last day or so, actually there are internal efficiencies and improvements we need to make, especially if we look at our discharge practice, to give an example, and actually that needs to be our focus, so we can do everything within our gift first to go as far as we can internally, and then we can point to external factors that could make the difference as well and what that gap might be. And I've got a really clear view on that I've described to my colleagues internally. I think what the report also does is point akin to the external diagnostic report that was published a couple of months ago, linked to KPMG work, to the work we need to do to redesign and transform our services moving forward. And again, I think there are now two strands that really give us a lever for that work. Firstly, we are looking at refreshing the North East Transformation Board. Terms of reference, that is underway, and I will chair that group. Again, that will be central to Grampian transformation opportunities moving forward. But then the second area is the subnational arrangements. I actually think that provides ideal ground, if you like, for that redesign work across the whole health system and across Scotland. And I think we need to focus on that moving forward, which is absolutely central to our sustainability as an organisation. Thank you.
Yeah, thank you very much, Laura. And I really endorse those points as well about us all needing to work to be as efficient as we can be in the situation we're in, and whatever our role in the organisation to increase our efficiency and do all we can do, I think is absolutely essential for all of us and across Grampian as well. So thank you for that, Laura. I can see no other hands on that one, so we'll move on. Thank you we've noted the Chief Executive's report. We'll move on to 5.1, the subnational planning paper. Just as an introduction to this as well, before I turn to Laura, Laura and I have obviously both been involved in meetings around the subnational planning, as you've seen in the Chief Executive report itself, and as we are obviously all working together to shape services to have a positive impact on patients right across our area in the subnational sense as well. Both Laura and I have emphasised in these meetings the importance of engagement with staff side from the beginning, and we've also both emphasised and highlighted that the unique features of remote, rural and island communities as well need to be acknowledged, and work needs to be done on that as we move forward in the subnational planning as well, and that's been taken on board through the planning structures as well, which is good to see. Obviously, we've got a period of implementation that needs to be undertaken, and that needs to be obviously done in a considered way to make sure that we are building and moving forward and not losing things happening already. So that will be a considered period of implementation. So with that introduction from me, I'll turn to Laura as well to talk about the paper. Thank you.
Thank you, Chair. Again, we'll take the paper as read and pull out a few key messages. Firstly, this refreshed statutory approach to subnational planning is seen as a key enabler for the delivery of the Service Renewal Framework, Population Health Framework and the Public Sector Reform Strategy. The proposal is to have two new collaborative subnational structures which will replace the previous 3-region model. And just for clarity, as the paper highlights, that is the first area is Scotland East, which NHS Grampian will be part of, and the second is Scotland West. So in simple terms, that means there will no longer be a North of Scotland region as it currently exists moving forward, and the boards that currently sit in the North of Scotland will move into the East or the West. And again, just to simplify things, all but one board, Highland, will go in from the current North of Scotland construction, will move into the West. The other boards currently in the North will move into the East region. Each area will establish a subnational planning and delivery committee to be chaired by the board chairs of Greater Glasgow and Clyde and NHS Lothian, but all boards will be represented on those planning and delivery committees, with Alison and myself, of course, sitting on the East Committee. As Alison said, the partnership and employee director roles and presence and contributions to the committees, but also the National Oversight Group, are absolutely pivotal, and those discussions are ongoing as we speak. There's a reference to the appointment of the lead director roles in the paper. Those interviews didn't happen on Monday and Tuesday of this week for various reasons, but are anticipated to happen this side of Christmas, so more to follow there. There are 4 shared priority areas initially that the East and West areas have been asked to look at. The first is the digital front door. So this is the new health and social care app that will be implemented from April of next year. So a digital priority front and centre. The second is further work to reduce orthopaedic waits. The third is emergency healthcare services, i.e. system flow for short. And the fourth is a once for Grampian opportunity around business systems. So this is looking at systems in relation to finance, HR and procurement, to give some examples. Plans for the East and West will be submitted by March and go through appropriate governance and approvals processes, with quarterly reporting commencing to ministers from Q1 of 26-27. The first East Subnational Planning and Delivery Committee meeting is on the 19th of December. And I think there are 3 principal benefits that fall out of the subnational arrangements. And just to boil those down really for board members and our community, the first is to reduce unwarranted variation, and with that reduce operational variation. The second area is clinical and financial and sustainability. And I think the third area, it just touches on some of the discussions we've had already in this meeting. It really formalises joint working and system-wide collaboration and takes that a step further than I think directors' letters have to date. And then in conclusion, I think the NHS Grampian contribution and engagement is absolutely key. We have made our position clear in terms of the voice of remote, rural and island, and I'm really pleased to say that both the Cabinet Secretary and the Director General for Health and Social Care have recognised that, and both health inequalities, deprivation and remote, rural and island will become that golden thread that underpins everything that the East and West does. And I think that's a really helpful step forward that has already been picked up on. We have been clear that there needs to be safe transitional arrangements in this next period so there are no unintended consequences for patients. And I think finally, as we've touched on, that partnership and staff side engagement is absolutely essential. So I will pause there, Chair. Happy to take any questions.
Thank you very much, Laura. And we've got lots of questions coming up here. So can I ask you to keep your questions brief, please, so we can move through them all. Hussein, please.
Thank you very much, Chair, and thank you for the report. I obviously welcome the inclusion of IJBs in the list of partners that will be engaged. I would hope that there will be a narrative set out very soon as to what that engagement will take and how particularly members of those IJBs would be involved in that. On to some questions, I think. One of the key risks in this is already stretched senior leadership colleagues who we want to be involved in this work. We want Grampian to be represented. We want Grampian to have that loud voice, as Laura indicated in her report back there. How are we going to manage that so that there are only so many hours in the day? We don't end up in a situation where we have inadvertent burnout. How are we going to support our senior leadership colleagues? And how do we see those priorities to this work, which I very much welcome, along with all the existing internal priorities that we're also going to talk about in the meeting today?
Yeah, thank you. Thank you for the comments on IJBs. Laura, do you want to take the point about capacity and staff?
Yeah, I actually don't think that's a challenge at all, because actually it doesn't change our commitment and contribution as is. It's just in a different form moving forward. Regional, when it comes to our role as board members and directors in particular, regional work or subnational work is a central part of our roles, as is national work. So I think that doesn't change things in that regard. The lead director roles are really important, and actually they're for a minimum of 3 days per week. And I think that's really key, that there is the right driving force in each of those director spaces to lead key pieces of work. And actually this is about reducing duplication. So I actually see it as a better use of all of our collective time rather than adding more to the pile in terms of senior colleagues' roles. Thank you.
Thank you. And Hugh, do you want to come on that as well?
I did, primarily with the aim of protecting poor Laura's voice. Right. So as I'd associate myself with Laura's comments, but also Hussein, just to reiterate and perhaps assure that we have existing forums through which each of and collectives of the director level leaders meet within the North region. We're already engaged in conversations across the East about how we combine those with what have previously been their equivalents in the Southeast into a set of East forums. So the totality of the work, therefore, won't be any different than what we currently do. It will just be in a different configuration. And again, just for transparency and openness, bearing in mind the important point you make about the required focus on a huge amount of important work within Grampian, those of us that are directors within Grampian have taken the view of not putting ourselves forward for the regional lead director roles at this time. We've got too much to focus on within Grampian. So perhaps in the future, that might be something that some of us choose to do, but we've made a very intentional decision not to do that at this stage.
Thank you. And Laura, did you want to come back?
I did. Just 2 further points, if I may, prompted by, helpfully by Hugh. If we look at 2 of the 4 priority areas, they are unscheduled care and planned care, which are exactly our areas. So I actually think that can only help us even further. And in the East, in terms of unscheduled care, I've agreed to be the lead chief executive. So again, that only helps us from our own improvement perspective even further. I think it's an entirely fair challenge around capacity for senior colleagues in particular. And the only I think pressure point I foresee in the next quarter or so, but I do think there's a genuine endpoint to this, is in this transitional period between the North effectively turning the tap off and moving to the East and West. But I think once we get to April, I don't see that double running be necessary. But to make sure nothing slips through the cracks, there may just need to be a little bit of double running through that transition period. But that aside, I don't see it to be a challenge at all. Thank you.
Thank you, Laura. And we've got lots of questions. Can I ask, if your question's asked by somebody else, you put your hand down and don't answer it, so we can get through what we've got here as well, please. Kathleen.
Yeah, thank you. I'm always a fan of reducing duplication, so it's very welcome to hear that. I guess my concerns are a little bit around the fact that obviously we have quite a lot of interdependencies with other boards in the North, like the Western Isles, Highland, and obviously the ones that are now going to be in the East. And it's just making sure that there's no, what assurance can you give me that there's going to be no artificial barriers or borders, so that there's elements where we do need to look east from time to time, and that we don't end up with this kind of false border that we can't collaborate across east and west, would be one issue. The second thing you kind of touched on, but I just wondered what the mechanisms were to monitor the unintended consequences, and also from a local priority perspective, just that assurance that it's not going to be diluted by the bigger plans for the sort of joined up approach of the East model.
Yeah, thank you, Kathleen. That first point about programmes that are happening already and links that are happening already, not being impacted negatively, that was something that we brought up at the beginning, has been discussed, and programmes are working and having impact. Obviously, need to be able to continue with those relationships with boards as well. So this is to help, not to hinder, I think, is the bottom line. But I'll turn to Laura as well, please.
Very much so. So programmes that are ongoing, I'll give a few examples just to make it as meaningful to colleagues as possible. So the neonatal reconfiguration work as an example, and the vascular, the new target operating model, those pieces of work, and Hugh, myself and others are involved in leading those pieces of work on behalf of the NHS in Scotland with other boards. They are continuing. We are seeing them through, and we'll make sure there are interim governance arrangements, and they were actually discussed just yesterday. So all of the programmes have been mapped across to interim governance forums, and they have been agreed at the NHS Scotland Executive Group yesterday, which of course I will communicate to board members over the next couple of days. I think we probably need to, not suggesting we are, but not be drawn into thinking about there being a wall between the East and the West. There is still NHS Highland being an example. We need a strategic relationship with NHS Highland. That is up to us to step into that space and agree what we want that to look like. So whilst there will be an East and a West, what there will be is one single PMO, Programme Management Office, underneath both. So there's standardisation and consistency and read across between two, Kathleen. So hope that's helpful.
Yeah, thank you, Kathleen. Thank you. Stephen, please.
Yeah, thanks, Alison. In a way, you'll be relieved to know I don't so much have a question, it's more an observation and a concern. Since the announcement of the subnational announcements was made in Parliament this time last month, it coincided with the NHS Grampian Board seminar and closed board meeting. Concerns I expressed in that closed board meeting continue to be the case, that actually at national staff side level there has still not yet been formal engagement. So while I absolutely welcome the paper, particularly the cover paper that that Laura has is presenting here, and I absolutely recognise the commitment to the partnership model of employee relations that we have in NHS Scotland within Grampian. I have grave concerns about at this stage decisions are being made, and I understand there is a deadline of the 31st of March and everything else, but actually time is ticking on, and there has not been the appropriate engagement, and frankly it feels like there is a risk of decisions being made without the full involvement and the appropriate engagement. So I don't necessarily require a response, but I felt it was important that was put on record with everything else going on. Thank you.
Yeah, Stephen, thank you. Thank you for putting it on the record there, and please be assured that it's an issue that has been taken forward, and things are evolving in the right direction along this as well. And Laura and I were obviously involved with colleagues, and not just us, with colleagues across the East about the importance of staff side being engaged in the work as we progress. So you can have the assurance from us that it's on our agenda and on the agenda of the East and the West, I imagine, as well, as a result of that. So thank you, Stephen. Bert, please.
Thank you, Chair. Good morning, everyone. Many of my points have already been covered, so no need for me to repeat it. But I welcome the comments that were made earlier about ensuring the voice of rural, remote and island boards will be at the forefront of our considerations. I see this as an opportunity to try and improve things for communities in the board area, and I'm sure we'll be seeking to take full benefit of that. I did say earlier that most of the things had been covered, but the one thing that I would like just to ask about, which maybe hasn't just been touched upon, unless I've missed it, is the whole governance around this. So in terms of the role of NHS Grampian in work that will now be undertaken going forward, does the governance of that remain with us as a board? Where is our position in all of this? And I did have some thoughts around the decision-making elements, which Stephen touched upon a moment ago, but I think that's been addressed. Thank you.
Yeah, thank you, Bert. On the remote, rural and island, that was addressed right at the beginning of as we started having meetings about this and thinking about how we integrate that absolutely fully into the work going forward. There's views on how to do that, and I must stress that it has the Cabinet Secretary's support as well as a key area of work. So remote, rural and island will be included very much at the forefront of this work. On the governance, Laura remains the accountable officer for NHS Grampian, and that governance system resulting from that remains. Laura, do you want to expand on that, please?
Yeah, of course. I think so. There will be an East plan, as I've described, with the deadline of that, and the West plan being the end of March of next year. We will have to work through our part in delivering that plan and how we will be held to account at the Planning and Delivery Committee for the delivery of that plan. But the same reports that come today in terms of the operational improvement plan and the next iteration of that as we look to 26-27, the How We're Doing report, our contribution to the East will still come through our board separately. And it does not, Alison is absolutely right, it does not change my responsibilities as accountable officer or the statutory functions that this board is responsible for. Thank you.
Thank you, Laura. Thank you. Okay, Bert, thank you. Colette, please.
Thank you, Chair. Very reassured by the comments on rural and remote, and also on avoiding artificial border risks. Those were two of my questions as well. The only one remaining for me relates to the patient experience, which I don't think we've touched on yet. It may be too early to say, but you specifically mentioned system flow and orthopaedics as two of the areas which would be a focus for this approach. Do you have any idea what that will actually mean in the real world for patients in Grampian?
Thank you. Laura, do you want to come in on that, please?
I think the honest answer is it's probably too early to tell. And I think as we get into January time, after we've had the first Planning and Delivery Committee meeting on the 19th of December, I think perhaps the board chair and I can bring back some further detail in terms of governance, the route map, if you like, between January and March and what that looks like, so we can plot in the touch points from this board's perspectives. But also, above and beyond the 4 areas, there is an intention to have a consolidated financial plan for the first time. And also, I think it would be helpful for us to then flesh out and talk through the remote rural and island golden thread in more detail. With that, the plan for how this will further improve outcomes for patients, because this is front and centre of this work, as well as the work around reducing health inequalities and deprivation, Colette. So early days, we will continue to bring back work through to the board as things are fleshed out. Thank you.
Thank you. Colette, do you want to come back?
Yes, please. I mean, I appreciate that, Lisa, or Laura rather. It's very early days, but I do wonder, did the Scottish Government do some detailed modelling before they issued this approach, which shows that this will in fact be a benefit to patients in the East and West?
Laura, can you comment on that?
Yeah, I think really this is around building further on the director's letter back from Caroline Lamb back in 2024 around collaboration and population health planning. I think it's really pushing the boundaries even further around that. And I think really what it's about, if you were to really boil it down, is how do we do the best collectively for the people of Scotland, and how do we best use the collective uses our capacity and resources. Thank you.
Yeah, and thank you. And that emphasis on collaboration has been part of the legislation around our role for a very long time, as you can see from the papers as well. So it's really building on that and taking it forward in a way that will benefit patients. But obviously there'll be more detail on that as we move into 26. Can I just bring Anne in, because I know she's under time pressure here as well. Anne, do you want to come in now, please?
It's just building on Colette. My concern is a very practical one, Laura. We have a lot of patients in the north, and from Dr. Gray's that would be going to Inverness. And my concern is like Colette's for the patient. How is it going to benefit or disadvantage them? People from the north where I am go up to Inverness, and my concern would be also for Dr. Gray's. So thank you, Alison, for bringing me.
Yeah, thank you. It's that connection with Highland. I think Laura's already emphasised. You know, we are not building barriers in Highland. It was the strategic relationship was the words that Laura used, and that will remain. So we do need to continue working with Highland for the benefits of patients across the north, and that work will continue as part of that strategic relationship that we have with Highland. So I think that's an answer, is it, Anne, without bringing Laura in?
Thank you for that assurance.
Thank you.
I'll just leave today and I'll be back.
Thank you. Thank you. Derek, please.
Thank you. Efficiency, Laura, absolutely 100%, despite any argument about funding or anything else, we've got to be efficient. Absolutely 100% behind that. I don't really have any difficulty with the discussion about this sub-national stuff. I think that's okay. I just find it a wee bit peculiar, given the shape of the country, that we've split it east-west. That I don't understand that at all. In behind that, utilising spare capacity around Scotland seems to be quite a good thing if we can do it. I would just wonder, have we looked at why there is spare capacity in some places and lack of capacity in other places? That tends to in my head tends to think about, well, is the funding going to the right place? So I'm sorry I'm coming back to the funding again, but utilising the capacity is one thing, but why is there spare capacity? Are we checking that? And just to re-emphasise the North issue, we were yesterday hearing about developments in the Murray maternity stuff, and that must continue. It absolutely must. And it sort of goes against the idea of this east-west split rather than the north-south split, which would have suited the geography of the country better. But I'll leave it at that. Thank you.
Yeah, thank you, Derek. On the east-west, I mean, that was a decision, but that was made by government and not by us. So we can't really comment on that, except to say, if you know, the overall east-west, its comparative sizes overall, I think is the outcome they were seeking. So I think that's important on that one. I think on the Dr. Gray's Murray maternity work, I think we've emphasised already how work like that that's underway will continue, and the relationships required by the boards to make that happen will continue. Laura, I'll pass to you for the rest of Derek's comments.
Yeah, I think in terms of capacity, it's probably less about spare capacity. It's more about have we got the right total capacity by specialty across Scotland. And I think the mutual aid exercise has been a real good example and test case of that, around where is the capacity that could be used by boards. But of course, the conundrum that comes into this is coming back to patient experience and travel that requires for patients. And I think it's actually been a good test case. But I think that's why orthopaedics is going first, if you like. It's about, is there the right capacity for orthopaedics in Scotland at the moment? And if not, what might that need to look like moving forward? And we're only just starting to get into that space at the moment, both at chief executive level, but also involving medical directors and executive nurse directors as well. I think just going back to duplication and efficiency, if I might, I think one of the real challenges that I see from the chief execs community is the principle and the starting point and default should be once for Scotland, because otherwise we get 14 different ways of doing things across territorial health boards, or the worst case scenario is adding the national boards to that and getting 22 different ways of doing things across Scotland. So I actually see this as a real lever for allowing us to implement once for Scotland well, but actually really sharing good practice and improvement more rapidly across Scotland as well, which at the moment is more challenging than one might think. Thank you.
Thank you, Laura. Thank you for the questions, Derek, as well. Thank you. Move to Mark, please.
Thank you, Chair. It's more of a comment than anything else, and I think I would have to associate myself with Stephen's comments with regards to engagement with clinical staff. I think there's been very little engagement with clinical staff that I'm certainly aware of. I think this was raised with the Cabinet Secretary on our annual review just last week, a week before, and I think that it does feel a little bit of this is being maybe done to us potentially without the collaborative approach to that. I think we would like to make sure the clinical voice is heard with regards to how these services are mapped out. Thank you.
Thank you, Mark. Laura, do you want to comment, please?
Yeah, I think two things. June and Hugh may want to come in. I think that's an entirely fair observation, Mark. I think a couple of things. I know there are meetings actually as early as this afternoon with medical directors and executive nurse directors to continue those conversations in the context of subnational. But we had a really good conversation with Caroline Lamb and Christine McLaughlin yesterday around the next phase in terms of that wider all staff communication, including clinical engagement and communication, and what that might look like. So please know both of those dimensions are very much work in progress and in people's thoughts. Thank you.
Thank you. Yeah. So yeah, to be continued, Mark, on that one. Thank you. Joyce, please.
Thanks. Yeah, I have some concerns about the financial consolidation and planning, which seems to be being done completely without discussions with the IGBs as well, because I thought we were moving more towards a wider system approach and more collaborative approach, but this seems to be pulling back into a completely NHS only approach, which does concern me, although I see great opportunities through the collaboration within the NHS. And the other aspect is the Ones for Scotland thing, which I think is great for things like terms of service and various aspects, but some services shouldn't be Ones for Scotland, because what's appropriate in a massive city is not appropriate in remote and rural. And I think that's very important that's brought into perspective, and certainly would come from work with the partnership approach. Thanks.
Yeah, thank you. That emphasis on local partnerships has not changed. That collaboration that we need to have with local partnerships, like our IJB colleagues here in Grampian, is very much part of the picture as well, and that's how we help the delivery of the overall aim as well. But as you say, it's maybe not reflected in the document that has been put out. So maybe we need to talk about that when we have our next East meeting. Laura, do you want to come in?
Yeah, just to reinforce that, really, I think it's doing both, Joyce. So the integrated service and financial planning work we are doing locally will very much continue in the North East. So please know that. And in fact, we're making good progress and can absolutely share that. I think as far as we will get to in terms of this financial year from in the new subnational arrangements are literally pulling together, if you like, the financial positions and submissions and having one scorecard. It won't be going any further than that. So practically, I think that's the reality for this year. I could not agree more in terms of Ones for Scotland. Of course, there are local nuances, and I'm the first to make the case for that. Please know that. That said, on the flip side, there are cases where we've argued for Ones for Scotland approach to digital, and then actually a number of boards have chosen to opt out, which means you get huge variations. So there are some areas that are no-brainers, and there really are no excuses for not having a once for Scotland approach. But your point is well made, and I couldn't agree more. Thank you.
Thank you. Thank you. That's the end of the questions and comments about this. I think it's been a useful conversation that you put things on the agenda for Laura and I to take to the East. And I hope equally we've been able to give assurance about what the work that's been done so far and the priorities being taken forward, and the emphasis on supporting our patients and staff within the process as well is clearly there, and getting the best outcomes for everybody involved as well. With that, can we note the subnational paper, please? And knowing that it's something obviously we will need to return to as things develop. Yep, thank you. We'll note that then, and we'll move to the forum reports. First of all, we have the area clinical forum report. Mark, can I turn to you for any additional comments you'd like to make, please?
Thank you, Chair. There's nothing really more than the paper. I think the only thing I would draw people's attention to, which I thought was very relevant, was the reported increase to violence and aggression towards our staff, and that the zero tolerance policy must be implemented consistently throughout our organisation. I think that increases in stress and anxiety within the patient group will obviously sometimes spill over into more challenging situations, and I think it's very, very important that we support our staff around that. Otherwise, the report is there, and I'm happy to take any questions. Thank you, Chair.
Yeah, thank you, Mark. I think that point about zero tolerance and violence and aggression is absolutely crucial and really important for us as an organisation as well to take forward. And it was something that I noted at the discussion at the ACF as well, and see it recorded here in the report as well. Laura, do you want to comment about the importance of zero tolerance?
I think Philip Shipman's going to come in on this one, Board Chair. Thanks.
Yeah, thank you. All right, Philip, please. He seems to be not available. Philip? Can we maybe come back to that? Or unless you want to say something yourself, Laura, we'll come back to it, I think.
I think firstly, it's really important to recognise that first and foremost, we have seen an increase in incidents, and every member of staff deserves to be safe at work, and we have to take a zero tolerance approach to this. There's clearly more we need to do, and what I was going to ask Philip to do was to describe some of the tangible actions that are underway, have started, and those planned for early in the new year. Chair, so perhaps if we could just pause there. I know when Philip's online, he'll return to this. Thank you.
Yeah. Or we can we put it in the action tracker as well to have it recorded that we need to follow back to this as well. Alison, could you record that, please? Because we do need to make sure this is top of the agenda. Mark, apologies for that, but we will come back to that because it's a really crucial topic at the time. John, please.
Thank you, Chair. Yeah, Mark is asking in the report if we're assured that it's the forum is fulfilling its role, and I think the points that are being raised do fulfil that really well, and I see significant assurance coming from that. So it's really that as a comment. I too was going to highlight the aggression and violence issue with is this something that's on the agenda or on the radar for staff governance? That was my question around that. Thanks.
Yeah. Joyce, would you mind me bringing you in to talk about that?
Yeah, that's fine. It's been something that's been high on the agenda for the last couple of years, specifically after a HIS report that came in a few years ago, and there's been a lot of work done in various areas throughout NHS Grampian on violence and aggression, but we are aware that there are areas where training hasn't been available for staff, or staff hadn't had the opportunity to take it up, and that's certainly been looked at the subgroups with regards to this, and I think there's a lot more that needs to be done, and also it's something that needs to be drip fed all the time to remind people that they don't have to put up with certain behaviours, and how to deal with it when they come across it. But I'm sure Philip can give more detail. That was what I wanted to cover in my question as well. Thanks.
All right, thanks you for that. Philip, zero tolerance, violence and aggression. Could you update us on the actions being taken? Because on the back of the ACF report, we were concerned about the way it's been mentioned and actions being required.
No, thank you very much. And apologies, I just had to dip out for a moment. So there's a number of things that are ongoing. So via the Staff Governance Committee, we're awaiting an update to ensure that bank workers are appropriately trained in prevention and prevention and management of violence and aggression when they're accepting shifts in areas of high risk of violence and aggression. That's currently with the nurse directors and the health and safety team, and that's going to be returning to the next staff governance committee. Via the Health and Safety Committee, as part of refreshing the governance and the focus of the Health and Safety Committee's work, we've identified that we need to do a number of deep dives into areas where we have particular concern. Violence and aggression is our first priority, and that's going to be taken to the next Health and Safety Committee, which is meeting in February. Coinciding with that, via the Health and Safety Expert Group, we're reviewing behavioural contracts for patients, relatives and visitors. And again, that's going to come to the next Health and Safety Committee meeting in February as well. But also just to bring that back into some of the implications that on the ground. So via kind of my own personal kind of visits to ED, it's highlighted the need to take this sometimes policy work into practical action and practical implementation. And again, that's going to inform, for myself in particular, all of those individual actions, because there is a lot of activity that we need to bring together and to focus that it's actually felt where it's needed most, which is certainly on the shop floor. So that's some of the work that's ongoing, and hopefully specifically with dates that we have in mind to bring that back to Health and Safety Committee. Part of the refresh governance is to ensure that Health and Safety Committee is reported in a more detailed and formal way, both to Staff Governance Committee and Chief Exec team as well, to ensure that we do have that focus on delivering actions that make that real difference.
Thank you, Philip. And could you just assure us as well that zero tolerance means zero tolerance as well? Can you emphasise that as part of the policy?
Yeah, absolutely. And I think that's going to the Professional Directors Forum as well. So we have different forums depending on whether it's a staff management policy or a clinical policy, and it's the Clinical Professional Directors Forum who approves the clinical policies, and I think that's going to the next Clinical Directors Forum. But yes, that was a very, very long-winded way of saying, yes, it is about confirming zero tolerance. Zero tolerance means zero tolerance. That was the mechanism for doing that. Sorry.
Yeah, given the importance of this topic, I think it's still important we have it on the action tracker for the board, and we return as a board to this as well. And Mark, you're nodding to that. So yes, we will return to this, and as we see those actions progressing as well. So during next year at some point when it's appropriate to do so. Thank you. Dennis, do you want to come in, please?
Thank you, and I certainly welcome Philip's comments regarding the zero tolerance is zero tolerance. I suppose one area that concerns me is there seems to be an increase in terms of violence and aggression, which is more to do with racism. And I'm just wondering if at the end of the day, we need to do more in terms of communicating out to our patient group or patient and families that racism is something that we won't tolerate, and it goes back to the zero tolerance element. But it just seems to be an area that seems to be on the increase, and I'm just wondering if there's any action that we can actually take towards that. Thank you, Chair.
Yeah, thank you. We obviously have our anti-racism strategy as a board, and we have various actions that were actually updated for lots of executives in the senior leaderships involved. At a recent seminar we had, a workshop we had about actions to do just that, Dennis, as well, and to put our strategy into practice about being about anti-racism. So I think that is certainly a part of the key agenda moving forward. So I will give you that assurance on the wider work of the organisation, and obviously this being part of that as well. And move to Bert, please.
Thank you, Chair. There is a lot being done in relation to violence and aggression, as we've heard from the various contributions. I just wonder if we are communicating to staff our awareness and acknowledgement of this, of our stance in relation to this, that we're aware of the increase and the work that is underway, and that the board is very much supportive of tackling this in the way that we ought to be tackling it.
Yeah, I've got both Mark and Laura wanted to come in on that, I think. Mark, have you comment on that?
I was just really using my hand, Chair, just
Right.
to thank everybody for their support around this. I think it's really important that we get the support around this, and I think that I acknowledge the input from everybody, and I think consistency applying the policy, I think, is one of the things that really must be implemented. So that was all my comment. Thank you, Chair.
Yeah, thank you, Mark. And Laura, do you want to pick up on Bert's comment then?
Yeah, I do actually, because I think it's really important. Thanks, Bert. I think we need a comms campaign around this, both messages for our own staff, but actually messages for our local community as well. And I think some really powerful case studies from across the UK where that's been highly successful. Thank you.
Thank you, Laura. And Alan, just come in as well on that.
Yeah, just to give the board the confidence. So obviously security comes under my remit, and I've been I had a bit of a worry in regards to the increase, just exactly what Mark's reported through the ACF, and I've done a piece of work with my Health and Safety Committee just at present to look at that and see if there's anything that can be ramped up in regards to communication and work alongside it. And I actually had a walkabout ARI with the security and the managers only Tuesday. So I got a really good insight into what's actually happening. But one thing I will say is the reporting is getting better, right? And that's something we need to be nice to say. You know, it's not to say that it's not increasing, it maybe is, but we're definitely increasing reporting, and a lot of things weren't getting reported before. So that sometimes is a knock-on effect of you think things are going in the wrong direction, but it's not really. It's actually we're getting better data. And if we get the better data, it's allowing us to break into areas of concern specifically, and also things that are currently recurring in regards to areas. And one of my observations was that the violence and aggression can be down to a difficult person or a difficult situation in a separate area of the hospital as well. So we really need to focus in on some of this and start some planned work directed in these areas.
Yeah, thank you for that, and that's helpful. Thank you. So we've certainly got a focus on this work. We're going to have an action to bring this back to the board at a later date to make sure we keep our eye on progress as well. And thank Philip for the actions that he's going to be putting into place. And obviously we want to see the progress on those. And obviously Joyce has told us the role of Staff Governance Committee within that as well. And I think I'd personally reiterate the point that John made as well, that that we have that assurance that the work of ACF is really important to the work we're doing, and really value the contribution, the discussion we're able to have on the back of that as well. So thank you, Bart, for that report. Thank you. Move on to the Grampian Area Partnership Forum report. Stephen, please.
Thank you, Chair. The report to today's board meeting is compared. It seems a bit lighter than normal. That's a quirk of the submission deadline for this. So actually, what's included in the report refers to what was discussed and agreed at GAPF in October. The November meeting has since taken place, and of course, what's subsequently taken place as well last week was actually, since the October meeting of GAPF, we've had 2 joint meetings of GAPF and the Area Clinical Forum. So, there will be subsequent reports to the board that reflect that content. So happy to take any questions, don't particularly have anything to highlight. Although actually, as I say that out loud, the one observation I would make is that in terms of the reduced working week, part of the non-pay elements of a previous agenda for change pay agreement, well in excess of 90% of the rosters have submitted their plans to, as to how to reduce the working week of staff, agenda for change staff by 1 hour from April 2026, prorated for part-time staff. So that's a significant amount of work has been done by an awful lot of people within the system to get us to that place. Clearly, it's not 100% quite yet, but we're definitely moving in the right direction. I'll stop now and open up for comments or questions. Thanks, Alison.
Thank you, Stephen. Any comments for Stephen or questions for Stephen? Philip, please.
No, not a question, just an acknowledgement and thanks to our partnership colleagues. So as we highlighted at the annual review, I think the way in which we've approached the agenda for change reforms and the reduced working week in particular is I think a demonstration of our commitment to partnership working, an example of that. And just to thank Stephen for his participation in the review of those submissions. So when we say we've had a response of 90%, that equates to not far shy of 900 rosters, all of which were scrutinised by a panel which included our partnership reps. So an enormous amount of work across the system, and just acknowledging the thanks across the system for supporting that and our partnership colleagues. So thank you very much.
Thank you. Can I just ask everyone to make sure everyone's on mute as well, who's not speaking? Thank you. Thanks, Philip, for that. And Dennis, please.
Yeah, thank you, Chair. Stephen, you mentioned the joint work with ACF, and obviously this has been extremely useful. Do you see that something going forward that will happen more often in the coming months, that more sort of joint meeting with ACF and yourselves, because it seems to be extremely positive. Thank you.
Yeah, thanks, Dennis. The short answer to that question is yes. Exactly how frequently and how that'll work out in practice, I guess it's for Laura, Mark, and I to put our heads together and sort of come up with that. But yeah, it has been particularly useful. Bringing the two sides of the advisory structure coin, I suppose, together. Lots of useful outputs, which, as I said earlier, we'll be able to, I'm sure Mark and I between us, submitting our reports and writing our reports separately, we will see the sort of dovetailing of that information, I would imagine, at the next board meeting. Thanks, Dennis.
Yeah, no, thank you, Stephen, and thank you to you, Mark and Laura, for bringing that together as well and working on it. I think it's a really good addition to our work and our engagement with staff to have that forum as well. So thank you to everybody who actually attends as well and contributes. I think it's really important. So thank you, Dennis. Okay, I can't see any other comments, so we'll note Stephen's report then, and then we'll turn to the IJB report 6.3. And Judith, I believe you're introducing this one. Judith.
Yes, I am.
Commenting.
Morning, Chair. Morning, colleagues. This is the routine report that we bring, which gives you the most recently approved minutes of each of the 3 Grampian IJBs. The report covers the key discussions and decisions that were made at those most recent board meetings, and we've also provided links to the most recently held board meetings, which took place in November and December. Myself, Lee and Sandy Reid are all here from Moray, Aberdeenshire and City. Very happy to take any questions and to field those to colleagues if they refer to their areas. Thank you, Chair.
Yeah, thank you. Thank you for that, Judith. I will just note we've obviously got the IJB finance report later in the papers, so if we can maybe take any more general comments here, and we'll look at finance later on. Any particular questions or comments from anyone here, please? Can I just ask then, Judith, on the paper, we've got examples in the IJBs that we've got presented to us about various work being done around unscheduled work care. We've got various examples of work being done around digital. Can we have the assurance that when work's done in one of the IJBs and positive learning comes out of it, that's shared across the system so that we can have some kind of a mutual benefit, I suppose, of that learning and benefits being seen across the system for patients everywhere? Thank you.
Yes, thank you. We've got a lot of good close working that we do as 3 chief officers and 3 IJBs, and most recently we had a discussion about our budget setting process with our wider teams. So some really positive learning there from what we're doing in each area, and thinking about how we ensure that we've got some consistent messaging around that. We're obviously working very closely as 3 IJBs, Health and Social Care Partnerships, with Geraldine and colleagues in Acute on the unscheduled care programme of work, and Lee chairs the programme board for unscheduled care that brings us all together. So a lot of learning from that as well. There's a number of other forums that we work closely in, things like discharge without delay, where we're not just learning from one another, but of course the work more broadly across the rest of Scotland, and that is also the case around unscheduled care. I know that in Moray we've had a number of engagement sessions with other partnerships with a similar geography to ours to see what we could learn and implement. So yeah, hopefully I can give you that assurance, and I don't know if Lee or Sandy would want to come in on that point as well.
Thank you. Can't see anyone. Sandy, do you want to come in?
Yeah, thank you, Chair. Maybe just as example, as Judith introduced, I think there probably will be colleagues in the call who attended the recent HOPE conference, which was done on a Grampian-wide basis, held at Cults Academy. We'd learned a lot there, shared a lot there. So just as an example, that was just Judith made me think about that one. Thank you, Judith.
Yeah, thank you. And obviously we've been talking a lot about efficiency, collaboration and shared work throughout this meeting so far. And obviously it's good to see that's in the IJB space as well. So thank you for that. Dennis.
Thanks, Chair. And it's really just to follow on what you've been saying in terms of that collaborative approach. And it's one specific area, Judith, I'm wondering, and I don't want to touch on the finance area here, but it's out of area placements. What work is happening collaboratively across the 3 areas in terms of trying to facilitate and work together to mitigate some of the impacts that out of areas have on each area? Thank you.
Thank you, Judith.
Thanks, Dennis. And yes, we look at this. I'll give you a Murray example on this one. We, as you know, have children's services delegated to the Murray IJB, and we do have a number of placements that we rely on out of area. Now, I would emphasise that for many of those individuals, that's absolutely the right thing to be done, and it's the right placement at the right time to meet that young person's needs where they are. We're doing some collaborative work with our colleague councils in Grampian around that, though, just looking at how we benchmark in the use of that. Often these are placements in the central belt, so children are at quite a distance there, and we're having some discussions with our colleagues in City and Shire around what else might we do and how might we collaborate together to ensure that we've got the right services as locally as possible to meet people's needs. So having some discussions around that. We do also collaborate in relation to out of area placements for adults. We have conversations as a group of chief officers in Grampian in relation to future developments. What might we be able to commission? What might we be able to do together that could have benefit for the population? So I'd say those conversations are at quite an early stage. These things can take quite a time to come to fruition, but it's definitely one of the topics that we discuss as a group of chief officers.
Thank you for that. Thank you for that assurance, Judith. Thank you. Okay, I can't see any other comments, so we will note the IJB papers and move on to 6.4, the Financial Recovery Board. Richie, one of our non-execs, are you able to introduce this for us or make comments?
Yeah, thanks, Alison. Just briefly in terms of what's there, you'll see that we've had 2 meetings since the board last heard from us. In fact, we also met last week, and that'll be updated in January when we meet. I think just a couple of pieces to highlight for me. I think we are developing a good momentum and tempo as part of the recovery board now. It's a good number of meetings we've had, and I think we're getting into some depth into some key areas that do provide some additional assurance. And I should just say a thanks to Mark for chairing the November meeting in my absence, just in terms of the running of that one. The other area is just about the deep dives, and I think that's an area where that does allow us that more in-depth scrutiny of particular areas, and that's those areas are identified for particular purposes, whether it's pressures, big spend areas, big savings areas. So it's not just for interest sake, it's with a bit of purpose behind it as well. So you'll see that there's been a couple of those in the last couple of meetings. We do want to pursue that in future, so there are some other areas for deep dives that we're looking at. I'll maybe touch on that later on in terms of the IJB paper, but no, just I think the details are there in the papers as set out, and just to thank colleagues from across various teams in supporting the recovery board. It's a fair bit of work goes into preparing for it, and it is some important activity that we take forward. So thank you. Happy to take any questions, of course.
Yeah, thank you, Richie. Mark, do you want to come in?
Just a quick comment, thank you. And it was about the deep dives, and the nursing and midwifery deep dive was very well presented, and there was a huge amount of information around that. And I think we have to commend the team for that. And I think it's really useful to keep on going at this and just keep picking away at these things and really look deep into where we can make, improvements. So just a comment, thank you.
Yeah, thank you. Dennis, just come in.
Thank you, and thank you, Richie. With regard to the deep dives, are you collaborating with the other committees that are looking at their specific deep dives in order that we don't duplicate? And are you getting sufficient data from our system, and are you identifying any areas that the data is just not available to you and needs to be improved in order that you can actually come to better conclusions. Thank you.
Thank you. Richie, do you want to comment?
Yeah, sure. Thanks, Dennis. In terms of data, I think we've got a lot of really good data. It's one of our conclusions that are kind of coming through the recent recovery board meetings. So it's not for a lack of good data, I would say, Dennis. So I would say I'm pretty assured, in fact, that we've got a good kind of context there in terms of the quality of data we get through, and in terms of I guess looking across the way. See, Sandy's put his hand up. Maybe go back to Sandy in a second. In terms of looking across that collaboration with other committees, I do sit on PAFIC as well, and I also sit in the audit committee. So I've got a kind of fortunate position in some respects. I've been able to look across the way as well. But equally, I'll take guidance from officer colleagues in terms of other activities that I might not be aware of. So we are coordinating that. And just to come back, I guess, to the purpose of the Financial Recovery Board, while its focus is on financial recovery, the deep dives allow us a more rounded view of the services as well. So broader impacts and cross-system working is a bit that we're kind of very conscious of. So I'm content that we're not duplicating or missing anything at this point in time, but I'm absolutely ears open in terms of any advice on that others might want to share.
Sandy's put his hand down, so I think you probably answered what he was going to say. Ask what comment. So Phil, I'll bring Phil in.
Yeah, thanks, Jerry. Just to build on Richie's point around data. So I think there's three sources that we're benefiting from at the moment. One is the comparative data that is provided through the external review, and that highlights a number of opportunities there. The second is the 15-box national grid, which looks at 15 key areas nationally and benchmarks us there. And then lastly, as part of our support from Scottish Government, we are engaging with the Financial Delivery Unit, who are helping to provide any information they can where we identify gaps as we go through this process. Thanks.
Thank you. Thank you. Phil, maybe this is my comments for you in particular as well. Obviously, we've obviously had assurance there that the data is available and there's links for the committees. What happens when there's a deep dive and actions are recognised from that? How is that fed back to committees so we don't lose outcomes from the deep dives in any way? Are you taking that forward to committees or in the next appropriate place, or to us as a board as well? What happens with the outcomes of the deep dives? Phil, do you want to comment on that?
Yeah, thanks, Chair. So I think the deep dives present the opportunities that we have identified through either benchmarking or through local knowledge and expertise. And I think as we go through the process and get to detailed plans at the end of March, which will come to board for approval, we'll then be able to go back and illustrate against each of those benchmark opportunities what is the realizable opportunity. But any key actions that come from the deep dives are on the action list, and we will pick up on each month. But through both PAFIC and FRB, we will highlight from January the increase in identified savings that we realised through each of those work streams. Thanks.
Thank you. Both Sandy and Alex wanted to come in on that. Sandy.
Yeah, maybe just to say that PAFIC is Performance Assurance Finance and Infrastructure Committee for people joining the board with our use of acronyms. Yeah, I mean, I think that Richie will have seen in his meeting, and we've seen in PAFIC that by very specifically asking for detail in relation to actions and how they've been actually delivered, we're now beginning to see a change in the quality and the nature of the information that's actually coming to us in the first place. So I think the system is beginning to gear for that sort of deep, much more meaningful information on performance, what has been delivered and when. So I think you'll be seeing it too, Richie, in relation to your particular board. We're certainly seeing it in PAFIC.
Thank you, Sandy. And Alex, do you want to come in?
Yeah, just a couple of comments, I suppose. There's one that, as Sandy says, the meeting is being run with an action tracker, etc. So we are closing that down as it comes in. We're obviously looking at what the format of the update that comes through to this board to provide overall board assurance that everybody knows what's happening within that area. And the second thing, again, just picking up on where Phil was going with regard to that, if we are finding areas within the deep dives that will deliver further efficiency through the value and sustainability programme, then that would also be featured through the How Are We Doing report. So I think we have got quite a good system in place for making sure board members are aware of what's happening. Obviously, if there was something within one of the deep dives that had a specific impact on, for instance, one of the other committees, such as staff governance, etc., we would look to make those links as well.
Yeah, thanks, Alex. I think it's really important to raise that in order to get that assurance as well about what's actually happening. I think there's no other comments on this, so thank you, Richie, for introducing that. And I think we're happy to note that paper as well. Thank you. Okay, which leads us on to item 7, which is our performance papers on the agenda. We've got 7.1 and 7.2. We obviously separate out the performance papers this time, and we have the How Are We Doing report about our own priority programmes, and then we have the operational improvement plan paper following it as well, using the same kind of format and same kind of data in both. I think it's really important to go back to that point we had in our action plan, that these papers, the processes are being redesigned to ensure that when we look at them as a board, we can draw better links between the performance levels that we're seeing as a board and the mitigation of the strategic risks as well. So it's a process of evolution, and this separating them out is part of that, but it really is important that we look at performance from this and we look at the outcomes of the various elements of work as well, in terms of the patient care we're delivering and support to our staff as well. And we need to have that assurance from these papers that appropriate improvement is being made. So I think that's a really important background to these two papers we've got in front of us now. Sandy, as chair of PAFIC, as you performance assurance Finance and Infrastructure Committee, do you want to comment as well on these papers? Thank you.
Thanks, Chair. Maybe just comment firstly on the first report that's before us. So the committee endorsed the Q2 organisational performance position, noting continued progress across the 3 change programmes that we've already referred to this morning. Governance has strengthened with programme boards now in place, and we welcome that strengthened leadership oversight at PAFIC recently. And the evolving performance model is improving visibility of actions, KPIs and outcomes. However, we did feel that performance remains very mixed, particularly in planned care and unscheduled care due to operational pressures. Assurance was taken from the maturing performance framework, but members of the committee emphasised the need for greater precision and much more evidence on actions and timelines, as well as more information on the impact of actions on the public and staff. Specifically, we will be expecting at future meetings greater evidence that actions are positively impacting on performance and that risk is being managed. Some areas of performance are not improving, so the committee will be looking for what further actions will be undertaken to manage this and manage this at pace.
Thank you very much for that, Sandy. That's a really helpful report from PAFIC on as we introduced these performance papers as well. And that will have been the points you make there will be noted and as part of our evolution of the performance papers as well, to make sure we are able to see the things that we need to see in terms of improvement as well moving forward. So thank you for that, Sandy. With that, I'll bring Alex in to introduce the How Are We Doing report, item 7.1. Thank you.
Thanks, Chair. And yeah, I think a lot of the points I was going to make have possibly been covered in the intros from Sandy and yourself, but there's 2 aspects I really just want to touch on in relation to this report. So the first aspect is the report itself, and as you'll see within that, we've added a graphical summary of our performance, so you can kind of see that on a 1-page performance on a page type of approach. We've also moved the majority of the operational improvement plan into a separate report, and we've moved some of the explanatory guides into the appendix. So as you've talked about, we've come a long way in this performance journey, and we're continuing to think about changes and where we can make improvements to try and simplify this report. The second and most important aspect I just wanted to cover, and I think you've picked up on it well in relation to your introduction, is the actual performance. So as you can see from the report, performance is mixed across our 3 priority programmes, and it's important that the performance is scrutinised assurances sought that the mitigations and plans being put in place are deliverable within agreed timescales, and we achieve the required and will achieve the required performance improvements and outcomes that we've discussed. So I think, you know, we have gone through that report again since PAFIC to update some of the comments that were made at PAFIC, and also made through the consultation process on this report to try and sharpen up some of these areas. But I would welcome comments and questions from the board in that regard. The final thing I was just going to say, Chair, and it's slightly unusual because normally the finance report comes first, but I recognise the reasons why we have put the performance report at the beginning of the agenda. So I just wondered, rather than kind of duplicate some of the conversation on the value and sustainability, whether I could invite Phil Tideman in, our interim Director of Improvement, just to give us a little bit of update on the value and sustainability programme, and then we'll circle. But that may close off some of the questions in regard to that bit. And then we'll still take questions on the finance bit if required. So Phil, over to you.
Thank you.
Thanks, Alex, and thanks, Chair. So happy to report that for the third consecutive month, we are exceeding our planned savings target and have delivered 27 million at month 7, so a positive variance of 1.6 million. I think this is evidence we are maintaining schemes previously implemented, but also seeing new schemes coming online and delivering in recent months, which is also very positive. I do want to reassure the board that looking at the increased savings at month 12 are due to 3 specific schemes, but we do have good confidence in their delivery. And then this month, we do fully expect to close the gap to 61.8 million and have improving confidence that we will both achieve the full 61.8 million in year that was approved by this board earlier this year, and consistent with last year's efforts, we will exceed the Scottish Government requirement to deliver 3% recurrent savings. There is obviously some moderate level of risk as we head into the busy winter months, and we will continue to monitor this closely, including maintaining all our existing pay and non-pay spend controls. And then just finally, in terms of next year's programme, we are on track with our 20-week development phase programme and intend to have a prioritised list of savings before the end of December, with indicative savings attached to many of those. This will then highlight the gap to our in-year target for next year, and we'll focus how as a whole organisation we respond to deliver that through Q4 and with a final plan to this board in March. Thank you.
Thank you very much, Phil, for that. That's very helpful. Thank you. And maybe that has preempted some of the questions that were going to be asked. But I'll turn to those questions now. Again, can I ask you to keep your questions brief, please? And if somebody else asks the same question, you don't say it again. Derek, please.
Thank you. A good report, guys. Well done. And the improvements mentioned by Sandy to come are welcome. My question is, where is the progress against the integration of Dr. Gray's and ARI? So that's the acute pathways stuff. Where is that being reported?
Who wants to come? Alex, are you going to come in on that? No.
Well, I was wondering if Geraldine wanted to come in or Hugh on that. See, Hugh's put his hand up as well. I'm not sure. I suspect that's included in the unscheduled care plan somewhere, but it's maybe not making its way through in this paper. But if Hugh or Geraldine's got a little bit more information, that'd be helpful.
Hugh's put it's Geraldine now. I think Geraldine, please.
Yeah, thanks very much. So the integration of acute pathways work is progressing. That is reporting in for the Chief Executive team in detail, and it is also now part of our new acute sector governance framework. So it doesn't fit into the performance report specifically because it is about service integration, service changes. So I think there is a slightly different governance that we have in place in relation to that, rather than it be in our how are we doing. But I think recognising that, again, there are aspects of planned care improvement that do relate to that integration work. So again, we will probably start to see a bit more detail of that as these the integration of those services evolves.
Yeah, could you maybe pick up Derek's point about how we as a board see that information, and where does it come to us? It goes to the Chief Executive Team and Programme Board, and does it then come? What's the next stage? Alex, do you want to come in?
Well, I know Laura's got her hands up, but I was just going to say we'll take that one away, Chair, and we can have a think about the best place to put that in place. Obviously, what we've tried to do at the moment is concentrate on the 3 priority programmes and really maintain the focus of the board on that. But let us go away and have a look at how that might flow through some of the other governance structures.
I've got lots of people with their hands up about to answer this one now. I'll come to Laura, maybe she can pick up everyone's comments and then we can move on. Thank you, Laura.
Yeah, I think it's probably worth highlighting, thanks Derek, is it a gap in terms of what comes through. As Geraldine said, it comes regularly through to Chief Executive Team and the acute governance. If it's a gap in terms of that holistic picture of what comes up in terms of the acute integration work between the ARI and Dr. Gray's, we can identify that. As you know, early next year, we're planning to introduce a Chair's Assurance report from Chief Executive's Team through to the board. So that's one way in which that would close the gap. But if a standalone report is felt to be necessary, we can look at that as well. Thank you.
All right, thank you. So I think rather than have any more comments on this, we'll put that on the action tracker as well to something to be developed for next year. So thank you for that, Derek. And please, Alison, can you note that as an action around that? Thank you. Hussein, please.
Thank you, Chair. Thank you for the report. Doing a bit of background reading for this, I was looking at the How Are We Doing report, but I also looked at the published statistics for waiting times that the board publishes on its website. And a significant outlier is general surgery. And as of 3 days ago, it was being published as 78 weeks. I think the next highest is 50 something. It was just to try and get an understanding as to how that statistic works. Is there something that general surgery captures that doesn't fit into all the other specialities there, and why is that such an outlier compared to everything else?
Thank you. I need to bring either Hugh or Paul, I think, in to respond to this one, please. Paul, thank you.
Yeah, I'll start. Thank you, Hussein, for the question. I think the first thing around general surgery in terms of its performance position, not the statistics. I'm not aware that we use any different algorithms or equations or data collection systems for general surgery versus others. And in terms of our position, general surgery, it is predominantly an outlier, because we've had a significant shortfall in our theatre capacity. General surgery relies very much on our ability to have a functioning day case surgical unit. So that's the first thing. So much of our TTG, time to treatment guarantee measurements, have been affected by the delay in returning our day case surgical unit to operational activity, and the fact that for the last, I think, 3 years, we've not really had a day case surgical unit. So that's a very significant fact. We've also, general surgery is a specialty that has a very large component of unscheduled care and urgent care. So much of our planned care waiting time performance is often compromised as a result of that sort of heavy bias towards unscheduled admissions. And thirdly, within general surgery, it's quite a big, it has a large number of sub-components to it in terms of different specialties. Again, many of those have a bias towards cancer and time critical surgery. So we are somewhat limited with abilities to deliver standard, routine, day pace, regular, low complexity services. And lastly, I think the other factor that we must consider is moving general surgical patients due to their specific patient requirements through our national treatment centres is very limited. Because of the nature of the case mix. So that's really where we are with general surgery. I hope that helps to say.
Zane?
I think there are questions perhaps to be asked. I mean, I think from a patient point of view, when you read that statistic, it's quite alarming in that table there. So I think there's something about how we message that. I think your explanation has been really helpful, Paul, and I thank you for it. And particularly, I mean, got 3 years, got legacy history as to where we are. I think there is something about communicating with the specifics of that day case unit, how we go forward, and where the improvement for that specific thing is reported, and how we tie that into communicating that. Because when you read it, it does just hit you in the face and you think, what on earth is happening here. But I do appreciate your explanation. It's perhaps something that we need to think about as a board, how we actually message that and report it. Thank you.
Yeah, thank you. I think these useful points, helpful points Hussein made, and maybe that's another action that we consider, communication of messages like this as well to patients. Thank you, Hussein. So maybe we'll note that as well from your comments. John, please.
Yeah, thank you, Chair. I find the report really helpful, and I'm starting to be able to navigate it. So probably not 100% there, but I'm getting there, and especially with the other reports on the agenda. So I can see the kind of modelling that's been and the thinking that's taking place with demand and need on the one hand and capacity resource on the other hand. Just would want to emphasise and endorse Sandy's points that can see this coming together, but the next step is to see how this is going to actually have the results that we want. And just to highlight that, I think on the unscheduled care programme, we've got a lot that says the deliverables will be completed and they're the kind of actions. And then I would agree, page 78, it talks about people being confident this is the right approach. So I think I would be assured by that. I think what I'd like to see to help get to that traction on change on the targets is a bit more about what will it actually take. So we get the deliverables and the actions in place, and that's, we've reflected on this in the past. That's a lot of where we've been. It's that next bit, being clear that the outputs that are coming through, we're clear on the assumptions about how that will result in changed KPIs and improvement. So I'd also like to just say thank you, because we've raised this at the last couple of board meetings, and we got the undertaking from Laura and the executives that this approach would be put in place, and to wait for this meeting to see it. And I'm saying thank you very much. I am seeing that. But I'd just like to be assured on this unscheduled care bit, because the bit I can't quite work out yet is that the recruitment and the funding we're not sure of yet, and yet we're saying we're confident we're going to get there. It seems to be subject to that coming through, and when do we need to have it come through to be able to be confident that we'll hit what we want in March? So that's my question, please.
Yeah, no, thank you, John. And I think that's really helpful, that the comments about what we've got in front of us now and how that's developed. I mean, I think there's also, leading on from that, there's an onus on us, a task for all of us as a board as well, in terms of how we take these papers where we don't feel that the actions are clear about what we need to do or what's needed to get the results. I think it's really important we point that out and give that steer as well about where we should go next and where we feel actions are maybe not in place yet. I think the comments you make that we can't have a paper based on hope these things will happen. We need to tie things down more precisely than that. So we do have a responsibility ourselves to give that steer and to tie things down and make sure that the performance does improve in the way we need it to and our patients expect it to as well. Geraldine, do you want to come in on that, please?
Yes, thanks, Chair, and thanks very much, John. I think that's a really valid point, and obviously, given the time where this report was prepared, we have since done an awful lot of work to understand in detail the impact that is going to take place as a result of all of the 18 work streams that are outlined in the funded plan. So that has been discussed in detail through the Unscheduled Care Programme Board, and actually what that is telling us is that we are focusing on the right things, but even within those 18 work streams, there are some which are actually going to give us more impact than others. So again, that really helps to narrow our focus down into those areas where we really need to deliver on it at pace, and how we then phase that. And obviously we can bring some of that detail back, obviously through the board updates, but really what we've identified is that for us to reduce our hospital occupancy from currently 108% down to about 98%, we have to create 80 bed days back. Now, that's not new beds, that's using our beds differently, and that's very much what we're focusing on through reducing our delayed discharges, reducing our length of stay, and reducing our admissions. So that's very much how we framed the plan. In relation to the question about additional funding, we are in dialogue regularly with government colleagues in relation to the additional social care money that's been announced, and also how we can use some slippage money that we have incurred just in the past couple of months, and that's just reflecting again the lead-in time for recruitment. So recruitment is on track. It is still on target for our dates that we've outlined in the plan, but we do have some slippage for this financial year, which we are going to be able to repurpose into some additional actions that the teams have already pulled together for. So we are just waiting to hear the confirmation for that, and that's not different from other boards in Scotland. That is all the same approach that's been taken elsewhere. But I think in terms of the specifics and bringing together the deliverables into actually what does that then mean, and how is that evidence that improvement that we're putting in place, we'll be able to give more detail of that in the next update report as well. Thanks.
Okay, John.
Yes, thank you very much. And just one other comment, different from that, but going through this, what I was finding was being able to focus on each of the programs, and I'm just wondering for in the future, whether at committee or the board, we focus our questions around each program, and then have a more of a conversation rather than
Yeah. We take the questions in themes like the papers in themes. That's an interesting, useful point, John. So
possible to think about. Yeah,
we theme the questions in order rather than have just hands up in general. No, I agree with that. And just thanks for that help, John. But just coming back to what Geraldine talked about, those 80 bed days that we need to address as a plan to improve flow. You mentioned as part of that avoiding admissions. Now that is about prevention work. It's about working across the system. It's about working with partners, and it's about that right care in the right place element as well. So can you just give us assurance that that work across the system and work with partners is happening to assist with that work? It's not avoiding admissions and not having people in hospital that need to be there. It's right care, right place, and working across the system is the response. Can you assure around that, Geraldine, please?
Thanks, Chair. Yes, no, I think that's a better way to describe it, and absolutely. So we do have a lot of work happening in this particular area. The expansion of the Flow Navigation Centre, of course, is one of those. We've had some really positive staffing models put in place for that with primary care, so they're able to staff in terms of the out of hours of GMED service, and again that's really helping with some of those interactions between primary care and secondary care, and some of the other aspects of the plan that the partnerships are leading on around about the discharge to assess teams, hospital at home, all of that, make sure that people actually get care as close to home as they can, and that they're not spending unnecessary periods of time in hospital if they don't need to be there. And again, it is really just that, as you've described, that early assessment, early intervention, right care, right place. And so I think that that's all feeling really positive from my perspective, and certainly the partnerships have been working on their aspects of the plan in that sense as well.
Thank you for that clarification assurance. It's obviously putting patient-centred care and making sure patients get the care they need in the place they need as well. It's really important. Thank you. Mark, please.
Well, thank you very much, Chair. The 3 programme boards, I think, are very welcomed. I think that we can then easily work out exactly, how we're progressing. I think VNS is obviously doing very well. The planned care 31-day and 62-day targets of cancer is certainly not faring quite as well as maybe we would like to see. And I wondered where the diagnostic capacity would be coming in from that, and whether there's any thoughts regarding services like radiology and how can they input into that diagnostic pathway and make it more efficient. We've already seen some improvements in head and neck performance around moving services and collaboratively working, but I just wondered if maybe Paul might be able to update me a little bit around the diagnostic pathways for cancer, because obviously it's very important to our patients. Thank you.
Thank you.
Yeah, sure. Thank you, Mark. I think the key bits to summarise would be that the Department of Clinical Support, or the services in clinical sports, in the Clinical Support Service Directorate, who deliver diagnostics and particularly radiology, have recently moved to a 7-day week. So that's the first thing. Secondly, we now have our mobile MRI van functioning and delivering additional activity at Dr. Gray's Hospital. We've now moved to early cancer diagnosis with direct access to CT scanning, and that in itself has taken around 40 to 50 days off the pathway, particularly for prostates. We've recently been able to significantly impact on our ultrasound scanning trajectory, which was deviating from our trajectory. It is now back online with our trajectory due to the recruitment of staff. I think yesterday we had a confirmation of some additional funding for diagnostics. I can't remember how much, but I think it's not a insignificant amount of money in terms of capacity. So they're the main things. So we've also now opened up our 4th endoscopy room in the day-case surgical unit as of the 27th of November. That will help. And we've been successful in recruitment to pathology recently, which will help our obviously reporting, but also the time to MDT and decision making, because one of the key bits really is that some bits of all of our cancer pathways are shared by lots of different services, and we've got the same group of people doing multiple different things. So there's some of the key highlights. Our most recent communication with both the Chief Executive team and government have suggested that our 31-day position in March 26 will be very much as we had said and committed to at 95%. We do think because of the delays in recruitment, particularly around some of our breast surgeons who we were unable to recruit to, and in 2 other services, we may be challenged to reach our board position of 85% at 62 days, but we are pretty confident from our modelling and analysis that we will deliver at least what the government expects Scotland to be at, which is around 70% for the 62-day pathway. I hope that helps, Mark.
Yeah, Mark, helpful.
Yeah, no, thank you very much. And those are the kind of things that I think that we need to be able to hear, because that then will be able, those mitigations will hopefully then translate into improvements and the performance will increase. And I think that's really important that we can get that messaging to the public of what we're trying to do to improve these pathways for our patients. Thank you.
Yeah, thank you for that clarity. Hugh, did you want to come in on that as well?
Yeah, I was just going to add, Mark, there are also 2 additional clinical endoscopist posts being interviewed for this coming Monday, which will align well with the 4th endoscopy room being opened up. So there's not only that physical infrastructure improvement, there'll be a workforce improvement as well. So thanks to Paul and the team for leading on all of that.
Thanks for that, Hugh. Thank you. Ian, please.
Thanks, Chair. Question is about complaints. Looking particularly at the page 60 of the pack. We have 32 complaints on a week on average in the first half of the year, which if you annualise it is about, I think, just under 1,700. Obviously accepting that not all complaints are a bad thing. In fact, many are a good thing because they can lead to improved performance. How does our level of complaints as an organisation compare to other Scottish NHS boards? And are we an outlier in terms of the number of complaints for good, too many or too few, or are we in with the pack?
Thank you. June, I was going to say, it's June, do you want to come in, please? I'm just checking you were there. June.
Thank you, and thank you for the question. So I've not looked at this in a long time, actually, the honest truth would be, and happy to do so and come back to it, but previously we have just been middle of the pack, as you would expect to be for the size of board that we have and the amount of patients that we see. So we were sitting pretty averaging, but happy to go and have a look at that and come back to you with a formal answer of what we are today. It was probably earlier in the year. It's not something we've looked at recently. Thanks.
Yeah, thank you, June. Can we take that as an action as well to come back with detail about how we compare with other boards on complaints? Thank you, Alison, if you can note that. Thanks, Ian. Colette, please.
Yeah, thanks, Chair. Mark, thank you for going into the detail of the cancer pathways. I mean, that's what I want to focus on myself. So you've actually covered most of it. And can I just say, Paul, it's great to have a more positive outlook on this. I think this is the best report I've heard on this. Very reassuring to hear that things on 31 day are beginning to move. Could I just ask about those that are still red, the breast screening, etc. What do you think the future is for those, and will the subnational approach help us achieve any of those targets?
Thank you, Paul.
Yes, so one of the things I think would be good to just sort of remind us is that the reports that we've put through for Q2, you know, much a bit like as Geraldine said, a lot of things have changed. A lot of things have changed. And in our breast cancer pathway, for instance, some of the noted deviations from the trajectory were because of recruitment issues. Now they've now been resolved, and through the theatre scheduling and prioritisation system that we have, we were able to reallocate theatre activity and capacity rather to the breast surgeons who have now got themselves in a place where the service is back on the trajectory that we had given, right? So there is something about the reporting lag between the quarter that we report and what we're currently doing, and so you know, we'll work out how we do that better next time. So we are back on trajectory. Our biggest challenge, as we have said in our cancer performance, that will compromise our position next year at the moment is urology, and urology pathways, particularly prostate, and it's down to nothing that is specific and unique to Grampian. We're dealing with the demographics, we're dealing with changing referral patterns, we're dealing with the change in expectations from the public, and of course what we can do. And there is the impact of the media and high profile individuals. So all of that is playing into our service. And I think, you know, urology is definitely one of those services where pre-COVID, much of our strategic intent was very much through the National Treatment Centre. And so a lot of our diagnostics, our one-stop clinics, our theatre capacity, our pathways in general were very much aligned to the development and implementation of an NTC Grampian. Now, that's been on hold, or well, that's on hold, as we know. In the interim, to help our current situation, we've recently received another, I think, £500,000 for outpatient activity, which will definitely improve our position. And the recent announcement of the Shore unit, as the chair announced, is our sort of a replacement of the NTC Grampian for urology. So there is, you know, there are many things, but urology remains the main thing that will weigh down our overall sort of a position as a health board at the 62-day level. Thank you.
Thank you, Colette. Do you want to come back?
No, I just want to thank Paul and the team. This is a much clearer report, and it's much easier to see where the progress is and where the challenges remain. So thank you very much, Paul.
Thank you, Colette.
Just finally, sorry, Chair, to say, I think Preston, I think you might be on the call there. Really does deserve that sort of acknowledgement. I think it's Preston who's been after me and our team to write a better report. So thank you, Preston.
Yeah, well, I certainly reiterate that. I mean, Preston, thank you very much for all the work. I know that you've taken a lot of lead on this as well, and made sure that the information is in the right place for us, and responded to all our demands about what we want to see as well, and the format. So really appreciate the work you've done on this, Preston. Just we can minute that particularly as well. It'd be helpful. Thank you. Richie.
Yeah, thanks, Alison. Two questions. One specific one for Phil, perhaps, in value sustainability, which I actually know the answer to, but I think the board would benefit from hearing the answer as well, which is around the total value of savings. projected to be 61 million, and almost half or close to half of that will be in the final quarter. So it's just about the profiling of that. So if Phil wouldn't mind just explaining the confidence that we've got that we still will meet that clump of savings in the last quarter of the year. And the second question I'll just say now is around this reference in the summary part of the report to the pace of change of measurable improvement being mixed. So any more general comments around how can we improve the pace? How can we get the pace at a level that we're more content with, I guess, to allow that improvement to be more explicit in terms of being able to be measured? So a question about pace would be helpful as well. Thank you.
Yeah, thank you. I'll come to Phil first of all, and maybe both Geraldine and Hugh and Paul maybe could comment about the pace. Phil, do you want to comment on the value and sustainability?
Yeah, thanks, Chair. So just briefly, I think the confidence in the second half of the year really is borne out over the last 3 months. There's been a material step change each month. Each month we've met that, which means that we are delivering the new savings we have implemented. I think in terms of the step change in terms of month 12, it's really around 3 schemes. So one's around agenda for change, non-pay reforms, around 6 million. One's around stock management for 2 million, and one's around IJB provisions for 3 million. And we monitor these very closely. They could be phased, but we put them into the month 12 position. So I can understand why there's concern about delivery of that in month 12, but we continue to have good confidence in that. And Alex, very closely working with the IJBs, continue to monitor their position, and we retain a level of confidence that will be delivered as well.
Thank you, Phil. Thank you for that. And Geraldine, just comment about the pace. How do we improve the pace of the work we're doing? Thank you.
Yes, thank you. So I think it's a really, really good point, and obviously we are keen to move on this as quickly as we can, particularly given some of the pressures we've seen in non-scheduled care over the winter. So I think there is a specific area where actually I think we can deliver it earlier than what we've set out in this report, and that is very much about our discharge planning. So we have made some really good progress in relation to some tests of change in relation to planned dates of discharge and using a different multidisciplinary team approach. So we've already started to see some really positive impact in a few wards that have trialled this early on as early adopters, which we are starting to get really good feedback just in terms of actually targeted focus on active management across all professions for setting discharge dates as early as possible and maintaining those. And what we're actually starting to see is already an impact in reducing length of stay from 48 to 72 hours to 24 to 48 hours, which again is really positive. So we are keen to roll that out as quickly as we can to some of the other wards, and we've had some really great discussions with our senior leadership teams in relation to how we do that, what support they need to do that. And we also have now data packs down to ward level so that actually the local teams, clinical teams can see and understand their own data on this and can set their own targets. And we have a process now in place so that we can bring all of that feedback together and monitor that and support our colleagues really to help with this as quickly as we can. So I think that's an example which isn't necessarily dependent upon funding or recruitment, but actually it's just good practice and management that we're really keen to progress at pace as much as we can. Thanks.
Thank you. And Alex, did you want to come in on that as well?
Yeah, not so much so on the planned care or on scheduled care, but I think Richie's comment at the kind of high level, I would just kind of go back to the improvements that we made in the governance framework over the last 6 months in relation to being able to see progress coming through, and reactive progress isn't moving at the sort of pace that we've got. We've got a good reporting system through at the Chief Executive team now, with assured reports coming through regularly that are providing good information to us to allow us to do that. So I think, you know, we can take more confidence from that approach and strengthening of the governance to help us improve the performance.
Yeah, thanks, Alex and Geraldine. That's a point I wanted to actually going to bring up as well. So I'm glad that Richie did it. I'm noticing the papers about length of stay. The comment was, we're waiting for operational cultural changes to take hold. And I was a bit concerned about that waiting. We can't wait for things to take hold. We need to act proactively to make sure they do take hold. And we need to have that grip and control around these areas, as we've had around the finance as well, to make sure that we're not just waiting, that we are making sure these things do proceed at pace. So something around the wording of that did worry me me about the pace. So I'm thankful for the answers we've got, and bring Laura in as well. Thank you.
Yeah, I just want to build on Geraldine's really helpful observations, Chair. And Paul and Geraldine led an absolutely superb meeting yesterday with our senior team, including our clinical leaders, around consistency of discharge practice. And I think our expectations are crystal clear, and that was set out yesterday. But I think there were some really helpful observations fed back around, can wards get some support, double run a little while, and then when the support steps away, the ward team feel comfortable running with that change and owning that change. So I think we had a really good set of conversations yesterday, but I think we've just got to be a little bit careful. And I'm the first one to move at pace, as you all know, but actually we want change to stick, and we want this to be sustainable. And there's something about taking people with us and people feeling like they own the change themselves. And that's a delicate balance, I think, that we're all trying to strike, in terms of being clear around we're not where we need to be, using the data to set that out in terms of the size of the opportunity, really set out clear expectations and how we will monitor progress and track progress with that engagement piece from a staff engagement and experience piece. And I think yesterday, for me, we struck that balance in terms of that engagement. There were great ideas whilst being clear on expectations as well. So I just think it's very easy to talk about pace, but actually if we are going to change the culture, we've got to go about change in the right way. And I think yesterday was a really good example of that. Thanks.
Yeah, I think that report on yesterday as well also answers my comment about the length of stay, waiting to see things take hold. I don't think we are waiting. I think that meeting yesterday was a good example of that. So thank you for reminding us of that as well, Laura. And just the only other thing maybe to bring out as well was in the unscheduled care improvements, there was a comment about sickness absence contributing to decline in pathways. And obviously this was before flu comes in and things like that as well, before recent challenges as well. So just a reminder, I don't need an answer now, but just a reminder about the importance of staff well-being as underpinning everything, and supporting our staff in every way we can, because all the work depends on the contributions to the staff as well. So so just make sure well-being is emphasised throughout. But I'll just leave that as a comment and because of where we are on the agenda. Thank you. Okay, can we then look at the recommendations for this 7.1? We have a huge list of recommendations here. Endorsing the Q2, July to September organisational and performance position, noting continued progress across the 3 change programmes, and operational pressures affecting KPI performance within planned care and unscheduled care. Assurance to note the actions detailed in the Q2 How Are We Doing report to improve KPI performance, and they're set out in the paper. To note continued improvements in the timeliness of complaints handling as part of the wider voice of our citizens' perspective. To note the limitations created by the timing lag of reporting, which means that recent operational developments in emergent lists are not reflected in the Q2 snapshot. And a decision to approve the Q2 How Are We Doing report and the continued utilisation of the performance model within the performance assurance framework to ensure activity translates into measurable improvements across the 3 change programmes. Can we agree those recommendations, please? And make that decision. Thank you. Okay. And we will move on to 7.2, the operational improvement plan. Sandy, did you want to say anything before we move into this as well, please, Sandy?
Yeah, just a couple of comments, and I will also, Chair, want to make a couple of comments in relation to finance in the next item, which we've been discussing about already, but there are some separate points to make in relation to that. But in relation to 7.2, it was agreed that the operational improvement plan will be reported separately from How Are We Doing report for the remainder of this financial year to provide a clearer focus on the 3 priority programmes. While progress is evident, recruitment delays and the timing of funding continue to impact on delivery. Committee members stressed the importance of moving quickly to embed proven models rather than prolonged tests of change, and requested a clearer articulation of risks and mitigations in future reports. And just touching on a point that both you, Chair, and Laura have made, we want to see a clearer description of how NHS Grampian is working across the wider system with its partners to address the pressures affecting us all, as including local authorities, IJBs, and the third and independent sectors, for example. The position needs to be that NHS Grampian and partners have to move on from simply sharing ambitions and intentions to delivering together the changes that are promised and required. So these are the main issues that were raised in relation to that specific focus.
Thank you very much, Sandy, for that. And with that, I'll turn to Alex to introduce the paper. Thanks, Alex.
Yeah, thank you, Chair. just to put, I'm not going to overly introduce this paper. I just feel that it's important to highlight that, you know, we've pulled out the operational improvement plan areas that stand alone and put them in this paper. Some of the operational improvement plan areas are very closely linked to the 3 priority programmes, so we've left them in there. I just wanted to make that clear from the outset. Chair, happy to, and I'm sure my colleagues will be happy to answer any specific questions on the report.
Thank you very much, Alex. And Hussein, please.
Hi, thank you very much. I welcome this paper and I welcome the separation from the How Are We Doing report. I find myself, however, having quite a degree of discomfort, particularly for the recommendations around approving this. A number of the points in this link to, for example, staffing and recruitment. It's mentioned around the discharge to assess work. It's mentioned around waiting times. There are a number of references to funding, which is not yet being secured, or we don't have a timeline for. Forgive me, Chair, whilst I just get my thoughts in order. I guess where I'm going with this is it would be really helpful to have some narrative as to what the external picture is around this, as well as the internal picture, because I have confidence in our execs that they are doing the internal work and the aspiration is there and the internal planning is there. But without, for example, knowing how we are dealing with the recruitment challenges that we've heard so much about in the past, without knowing where discussions are with the Scottish Government over the funding that we need to progress some of this, it does make it rather difficult to be able to say concretely that we are assured that we're heading in the right direction. It feels like a part is missing, and colleagues may be able to frame this a lot better than I can, but I just wanted to put on the record where I am with this. So it is just to say, what considerations have we given to that external narrative being included in this, because I feel that we're not entirely putting forward a full picture, and I mean no disrespect when I say that.
Okay, thank you. I don't know who'd like to bring in on that comment about the external being part of the picture as well, in terms of what we're doing partners, in terms of funding coming forward as well, and not seeing that in any timeline sense. Alex, do you want to start with this maybe?
Yeah, okay. I think that's a reasonable comment that Hussein's made there, and I think what I would do is in the next iteration of this, kind of think about maybe pulling some of those elements out into a separate column might be helpful in trying to bring that in, if that gives a little bit more assurance in relation to that. But that's where my head's going at the moment, is that maybe you need a little bit more information in that, and that's certainly something we could try and reflect in the next version.
Yeah, we maybe need to relate how we're working with the East, and that'll come on board as the East starts operating as well, and delivery of the East will be part of that, and maybe something about timelines of expected funding, so we can see clearly when we're expecting something to come in as well. Might be useful on that. Paul, do you want to come in on this as well, please?
If I may, saying, would it help, for example, in the planned care section, in terms of the external contribution, to have things that summarize our sort of network approach of having planned care delivered for our citizens out with our board, and or sort of the end product of training programs, and people are coming off training for recruitment. Is that the sort of information that you're looking for?
I think that would be helpful. I mean, I guess where I'm at today is, as it is, I'm not sure I can 100% agree to these recommendations. I think Alex has given me quite a good deal of confidence for future reporting and building that in. But for me, there are still unanswered questions, such as, what are we doing with recruitment at this current moment in time, for us to be able to look at the paper we have before us today that says we need staff to be able to deliver this, that says we need funding to be able to deliver this. Now, we have to make a decision one way or the other, but I think it would be really helpful, and I apologize for belaboring the point, but it would be helpful if we could even just have some verbal narrative as to where we are with some of these unknowns, to supplement the internal planning and the aspirations that we have, just to give us that confidence between now and next quarter. If we had that, I think that would help assure everybody that, you know, the two parts of the whole, in effect, are working together, and that we actually can have confidence that these will be delivered.
Yeah, and I think you make an important point about the verbal updates as well. And obviously, we're asking questions to give us that assurance, and we're having responses in order to move forward with that. And obviously, there's the time lag as well in the reporting and what's in front of us. So you've raised two particular issues there. That maybe we can think of addressing that recruitment. Can someone comment about how recruitment is happening since this report was written, and is there any update on recruitment, Geraldine?
Yeah, thanks. So I suppose, yeah, I think that's really helpful. And obviously the recruitment is a iterative process. And what we were looking at, actually, similar conversations to Unscheduled Care Programme Board about we need that kind of live tracker so that we can understand out of the 114 additional posts that we have in the agreed plan, how many have we got in post, how many are out to advert, how many have we got interviews for, so that just actually we can understand that, because obviously that changes day to day. So it is a kind of moving feast, but I think we're really keen that we have just got that live understanding of it at every given point. Now, each of the work streams know their own details, so they know how many posts they've got, but again, it's just bringing it all together because we do have so much activity happening. And I would say again, at this point, we are still confident again in the recruitment. We haven't hit any particular barriers and any issues, and where we have seen anything that again on further examination we think could be staffed differently, then we've given the teams the agility to actually go back and look at that within the agreed funding envelope, perhaps just to change some of the designs of the posts. And we've got an approved governance process for managing that and sign off of that. So again, that is being managed at the programme board level. I think in relation to the additional funding, where that so obviously we have got the approved funding for Unscheduled Care Improvement Plan, the supplementary funding that we're discussing. Again, that is quite an evolving process that we are in dialogue with regularly. So we can think just again, how do we provide those live updates in relation to where we've reached with that. But I think probably the confidence levels are there in terms of the slippage funding. Certainly that there was a meeting of the National Flow Board where they agreed in principle boards could reallocate their slippage. But again, there just does need to be that clarity on what it's being repurposed towards. And then obviously that will be tracked and monitored the same way as the existing plan. So I think what I'm saying is that there are lots of details there. Again, it's just what's helpful for this board, given obviously the time and the lead-in time that we have between the papers and then coming to the meeting. Thanks.
Yeah, thank you. I'll bring in Colette and John, because maybe they're asking things that will help Hussein's question as well. Colette, please.
Yeah, it is related to Hussein's point. I mean, a number of the targets that are set out in this paper relate to delivery by the health and social care partnerships. And I'm going to come to this in more detail in the finance paper about the IJBs. We've talked a bit today about the financial interconnectivity between this board and the health and social care partnerships. And yet at this point in the year, there's still a level of uncertainty about what the IJB and Health and Social Care Partnership budgets for next year and beyond will be. That's all up for discussion. So there's something here. I want to come back to it later in the more detailed financial paper, but there's something here about how do we ensure that there is a greater level of joining up right across the system. And again, will this form part of the subnational planning? So to me, there's a risk here that some of these won't be developed if the budget situation doesn't go the way it needs to deliver these. I'm sorry if I'm not being clear, but I will come back to it later.
Yeah, thank you. And a point about the IGB and the joined up system approach. Geraldine, do you want to take that as well? Because obviously you're working on the Unscheduled Care Board with other partners as well.
Thanks. Yeah, I can certainly speak to some of the conversations that we've had for the Unscheduled Care funding specifically. So we're really clear about which of our programmes of work are recurring and which are non-recurring. So I think that has all been factored in, and that's been very transparent in our plan submission and our reporting. And obviously conversations between finance colleagues have taken place in relation to how that's going to look and what needs to be in place to support that. So that I think has been an enabler actually for the programme hasn't given us any issues so far. I think the only maybe aspect in relation to that is that we obviously, for the unscheduled care additional funding, have to spend it within the financial year that it's allocated for. So the government have been very clear about not being able to carry over money or not having anything which has a kind of tail for the additional social care money, which must be used for this financial year. So we are having lots of dialogue in relation to that in terms of what are the parameters and then what are the options and how can we best make sure that our plans fit round about them. But I think certainly, obviously, would leave others to comment on the broader picture, but I think we do have a good amount of clarity for the IJB's financial side of their delivery. Thanks.
Thank you, Geraldine. And we'll move on to John, please.
Okay, thank you very much. Yeah, I had the kind of question which kind of, I suppose, follows on from some of that, which is about the next operational improvement plan and the work that we're doing around that. I mean, it's very helpful that through the conversations today, we're talking about getting to the targets as best we can, being accountable for that for March 26, but doing so in a way that is robust to try and make sure we can sustain it and build on that. So I'm just, as I was reading this, I was mindful of kind of thinking there's very much a focus on March 26, but that'll come and go. And where's the planning? Is the planning already starting to come together so that we've got, a 24, 36 month line of sight of where we're going with the strategic work? So that's a question. Just an observation, and it links to this being done system-wide with the likes of the IJBs. Page 109, there's reference to this primary care board as a possibility. Earlier on in the agenda, it was referenced under the action tracker heading as it's going to be put in place. And I don't think certainly hasn't come to the IJB that I'm involved in as yet. I do think it's something we have to just take care of, that if the IJBs are going to be part of it, they do need to be part of it and not get something as a done deal later on. So that's just an observation. My question was on the first part, which is the planning that we're doing going to see us carry on through, and are we already thinking of the next operational improvement plan? Thanks.
Yeah, thank you. I think on the primary care board, I think the point's well made that we need to make sure everyone is involved in developing that as they should be involved in developing it. And I think the update at the beginning of the meeting was key in that one. On the March 26, I think these are particular targets being given as part of a particular plan to us by the government that we're working towards here, and with the particular end dates there for action to be seen. And I think the focus here is very much on what's required of us in terms of that. But obviously, as a board, we need to have our own work going on beyond that as well. So there is a challenge there between those two things, I think. But Laura, I'll bring you in on that, please.
Thank you. Thanks, John. So just building on the board chair's comments, I think there's a number of moving parts at the moment, and there are a number of priorities we have as an organisation and system, and there's a number of national updates that we are waiting to come down the line. But in response directly to your question around, are we looking ahead and planning? Absolutely, yes. So let me just describe some of the key components of work that are underway that hopefully will give you some confidence and assurance. So there's a subnational work that is just being stood up, and the 4 priority areas are quite clear there. We'll continue to keep the board up to date, but I think we've gone as far as we can do for today. In terms of the next iteration of the operational improvement plan that will come down the line from the Scottish Government, I would anticipate in the next month, that will look beyond the current operational improvement plan, which always had a 12-month currency, which runs out in March. We will await the next iteration of that operational improvement plan. But as the board chair said, that is a Scottish Government document, not something that we produce. We implement it and make it meaningful from a local perspective. So that document is awaited. The other dimensions are the service renewal framework and the population health framework, and Scottish Government under Christine McLaughlin's leadership are working on what are the programmes and key pieces of work that now need to take those really important frameworks and policy documents forward. That will come down the line within the next month with the operational improvement plan. So as those national machinery is going and all of those pieces of work are underway, and board chief execs and others will have those conversations in the next 4 weeks or so. Before Christmas, I have a meeting with our planning team to work on our own priorities, looking ahead to 26-27. And as we go into January, we will build on that work, looking to refresh the plan for the future. And when the national documents drop down the line, we'll bolt those two things together. So hopefully that's helpful. Thanks, John.
And obviously there'll be an update to committee, to the board when we have that information. So we will return to this throughout the year. Thank you, John.
Yeah, no, that's helpful, and it also helps us as committee chairs thinking ahead. So the work that we're doing to underpin this as well. Thank you.
Okay, thank you. I can't see any more hands up on this. Are there any particular questions or comments about what's actually written in the operational improvement plan that we've got here going forward? No, okay. I think we've covered our discussion in the previous comments we've had as well. Anyway, so thank you for that. I'm going to go through the recommendations slowly this time in case we want to alter anything of it and as we go through. So the operational improvement plan, the first recommendation is to note the proposed change to reporting of the OIP as a separate report within the How We're Doing report. I think we can note that. Thank you. To endorse a return to separate reporting of delivery performance of the OIP priorities by NHS Grampian, and that they will be excluded from the revised board How Are We Doing report for the remainder of 25-26 to provide a more focused and targeted reporting against the 3 change programmes. So keep the structure. I've agreed that one as well. Thank you.
Agreed. And
then assurance to firstly a shared performance indicators of the OIP reference critical areas, planned care and unscheduled care are adequately addressed through the How Are We Doing report. Got nods for that, thank you. The actions addressing the remaining OIP critical areas are sufficient to support its prognosis for completion by 31st of March 26. Critical areas of focus showing anticipated minor delay are improving access to treatment, CAMS and psychological therapies, the shifting the balance of care, frailty services and dentistry, critical and digital and technology, digital dermatology pathway, and the operating theatre scheduling tool. We agree with that? Thank you. And a decision to approve the Q2 July to September OIP report, confirming that its progress towards completion by 31st of March 26 is on track, and that the level of detail provided offers sufficient assurance to the board that delivery aligns with stated commitments. Hussein, please.
Thank you, Chair. And I apologise for keeping colleagues on this. I realise that we have a large agenda today. I think that Geraldine, it was towards the end of her comment, there was one sentence that she mentioned, which I think certainly gave me a lot of assurance. And that was when she said, and I'm paraphrasing Geraldine, apologise, you said something along the lines of, and we are confident that we can do this. I think we need that confidence statement to be built into all future reporting. And I would also like to see something in these recommendations that show how we're going to evolve from what we have now to what I think we've agreed to do in future versions of this, which is to bring that external content in. And the reason I'm saying I'd like to see these incorporated into the recommendations is because I think it's important we show how we're evolving this and how that then ties into the scrutiny that we're going to have, because there is that realization that we can't simply do all of this on our own, that there are these external factors, and we need that entire context body. And I just think it's probably good governance to be able to see across the recommendations from paper to paper that the board has actually looked at the evolution of this, rather than we just have an updated paper in a quarter's time where the stuff is in there. There needs to be some kind of trail and golden thread through it all. And I would therefore appreciate if we could maybe consider either adding something into the approval recommendation, although I appreciate the word approve maybe doesn't quite capture it, or putting it somewhere in the structural recommendation, please.
Yeah, I think maybe there's 2 separate things here. We can approve or not the paper we have in front of us, and we can seek changes, amendments in future, so that we have the things that you mentioned here. We have talked about a live record and as part of improvement going forward. I think maybe good to keep them separate, but Sarah, I'll bring you in, please, for advice on this.
Yeah, so we've agreed process changes through and noted them on the action tracker for the how are we doing previously. There's some process changes today for the operational improvement plan. I don't think that needs to be a recommendation. I think we can just note it as an action on the action tracker. I don't see the need for a recommendation here.
Yeah, all right, because we've already got the action on the first action on the action plan is constantly updating what we're doing to be relevant. We've had examples here in terms of external, in terms of recruitment, in terms of funding, in particular, Hussein, that you brought up. Do you want them as a recommendation, or do you want them as noted as things we'll focus on?
Can I counter propose then? I'm happy to accept Sarah's good offices in terms of the action tracker. She's far more knowledgeable of this, but I would like to see something in the recommendations that says we've taken assurance in terms of our officers' confidence in this, because I think that's really, really important, because at the moment that is not coming through in the report as is. And we've heard verbally from Geraldine today that our officers, our execs are confident in this taken through, and that needs to be put somewhere.
And that will be put in the minutes of the meeting. So we often give additional assurance and additional information in the discussion, which is recorded in the minutes of the meeting, not the recommendation. So we're in danger of going down a very council-focused pathway here, and we're not a council. So our use of recommendations is not the same as the council and IJB approach. So I would just caution against needing to have everything you discuss, meaning that we amend recommendations all the time, because that's not the usual practice here.
Yeah, so in the recommendation we've got talks about the level of detail provided, and obviously the level of detail provided is the report and how we've discussed the report in the meeting as well. It covers both. So can we note these as actions we want to take forward, and we will take forward in both the action plan and make sure they're recorded in the minute? Would that be enough for you to say?
Yep, if that confidence from our execs is noted in the minute, I'm happy with that.
Brilliant, thank you for that. So can we get back to that final recommendation then, to approve the OIP report, confirming that completion's on track by March 26, and that level of detail provided offers sufficient assurance to the board that delivery aligns with stated commitments. Can we agree that, please?
Agreed.
Okay, and thank you. And with that, we're very belatedly going to take a comfort break. I think everybody needs it, and we're very late with that. So can I suggest, what's the time now? 12:30. Can I suggest we come back at 12:40, please? Thank you. 10 minutes. Thank you. Okay, it's 12:40. So hopefully everyone is back. I would appreciate if board members could put the cameras on so I can see the board members, please. Great to do that. Thank you. And we'll move straight into the finance report. Sandy, you said you wanted to say something before this report.
Yeah, just a couple of comments, Chair. I won't repeat things that were said earlier on. I mean, I suppose some of the headlines from PAFIC. I mean, we noticed that there are enhanced governance arrangements being put in place, and the value sustainability programme is broadly on track, with the savings delivered to date and the confidence in achieving the target around that. Planning for 26-27 is well underway, which is also welcomed, and we have welcomed progress but noted the need for recurring savings and sustained momentum beyond March, and that although a lot of foundations are in place, that now has to become business as usual as we move forward. Concern was expressed by committee members about the need for greater pace, though. This is a recurring theme this morning. And with us being in month 8 of the financial cycle and now having entered winter, there was some challenge regarding the optimism in the reports that the financial position would improve when it's been said that it will improve. There was an acknowledgement of the work being undertaken by finance colleagues with IJB Chief Financial Officers and Council Section 95 officers, but the committee also stressed the need for leaders and budget holders across NHS Grampian, not just in finance, to ensure there's sufficient accountability, ownership and control on spend. I think these were the main issues that were raised in regard to finance, Chair.
Thank you very much, Sandy. Thank you. And with that, I'll turn to Alex to introduce the paper, please. Alex.
Thank you, Chair. If I turn to 2025-26 first, you'll see that our current trajectory is an overspend of £2.1 million over the £45 million maximum deficit support provided by the Scottish Government. However, we're confident that we will deliver an overspend no greater than £45 million at the end of the financial year. Our financial position is holding month on month, and if anything, slightly improving as we see more savings coming through as we near the end of the financial years. We can't, however, be complacent, and we need to continue with the good work we are doing to get our savings fully embedded, as this will help to support next year's financial position. In relation to 2026-27, officials from the Scottish Government confirmed that our maximum level of deficits for sport for that financial year will be £36 million. Based on our high-level projections, it is likely that NHS Grampian will need to deliver approximately £40 million of new savings next year to close the gap between our expected costs and the maximum deficit support. These figures are helpful, but should be seen as provisional until we get the grant settlement information through in early January. We must continue to improve the financial position year on year and return to financial balance as quickly as possible, whilst at the same time ensuring that we understand and mitigate the implications on our services, performance and patients. Chair, there is a detailed report on the IJB finances, and it'd probably be better to leave any questions in relation to the IJB and how they impact on NHS Grampian's financial position to that paper. That was all I was going to say, and I'm happy to take any questions on the report.
Yeah, indeed. We'll leave the IJB questions to the next paper. Hussein, thank you.
Thank you, Chair. You're very kind. I thought after the last paper I'd used up my quota of interventions. I just want to get a little bit of understanding as to the thought process here, and I'm not inferring anything one way or the other, but if I read the paper correctly, as I think Sandy has inferred and Alex has just mentioned, obviously we're currently in a position where there's a 2.1 million projected over. If I read the paper correctly, we're still telling the Scottish Government that our intention is to meet the 45 million. We're just entering the most challenging time of the year at the moment with the new year, with the winter pressures, and obviously the whole, 3 months is still a long time in any climate. So I suppose I'm just wondering on your kind of insight into whether we should be being more conservative, almost looking at the adage, under promise but over deliver, or maybe it's the other way around. In terms of that, should we be telling them that we can do the 45, or should we be perhaps telling them what the position currently is and then delivering the 45 when we get there? I'm not inferring one way or the other. I'm just putting it out there to pose a question.
Thanks for saying that. The crucial thing is we do deliver the 45 at least, if not more. That's absolutely essential. We do get to the position, and we've got our value and sustainability work and other work that's ongoing in order to help us get there. And if those measures aren't enough on their own, we need to look at other measures because that is something that we do need to achieve. Bottom line. So I think that is the message behind that. Is obviously this paper relates to a time as well, a point in time, and obviously we're moving on from that as well. But I will bring Alex in now. Having said that, Alex.
Yeah, I think winter is always a challenge within the NHS, as we know. We have factored some of that additional cost that we may see coming through in relation to that into our forecast as it sits at the moment. So we do have some level of flexibility for that coming through. But as I say, when we're looking at the figures on a month-by-month basis in detail, and we are seeing that the position is holding, and if anything, slightly improving. I'm confident that we'll meet the £45 million. And I think the point that you've made, Hussein, is that we've taken a prudent approach in relation to that 47.1 million at the moment. But what we're looking to do is to have a really good look at that at the quarter 3 and make a position on that at that point in time. So as it stands at the moment, if things continue as if they have done at the end of December, then I would be looking to reduce that forecast to the £45 million because I've got more confidence that we will be able to deliver on that.
Yeah, and to come back to the point that our responsibility as a board to make sure that we meet our financial targets is on all of us to do that. So if we are not assured, we need to be pushing for more action to be taken on other aspects as well in order to reach that as well. And we have a responsibility to make sure that target is reached as a board as well. Thank you. Mark, please.
Thank you very much, Alex, and thank you for the report. And obviously, as member of the Financial Recovery Board, I do think that we're really looking very carefully at these things and keeping on track. And hopefully we will, and I'm assured by your confidence that we hit the 45 million, and that is absolutely where we need to be. Just one of the narratives around page 144 of the pack on the value and sustainability programme. Maybe Phil would want to answer this. I think I know the answer to it, but I think it'd be important to flesh it out. Is the increase in the savings from February to March. Obviously, there's a steep climb in that. I just want to know the narrative around that and how that's achieved. Thank you.
Thank you. Phil, do you want to come in?
Yeah, happy to take that. So there are 3 schemes that really reflect that jump. So one is around Agenda for Change, non-pay reform, and that's about 6 million in saving. There's stock management related to our procurement team for about 2 million, and then there's an IJB provision for 3 million. So that accounts for the majority of that, and we have full confidence that will deliver, but we do monitor that. It's a phasing issue we've done this year that maybe in future years we won't do.
Okay, thank you. Thank you, Mark. Dennis, please.
Thanks, Chair. Yeah, we will reach the 45. I'm assured that we will, given the narrative and given that Alex and Phil, I think, have explained as to how we're going to manage this. My question really, though, is, and it's about an earlier comment that Laura made and about the internal efficiencies. And it's how sustainable is this going to be in terms of the impact going forward? Because we're looking at a really steep saving going forward. And I know that internal efficiencies, but it's the impact on that patient care and the clinical services. I wouldn't anticipate that we'll be compromising on some of those elements, but it does give me some concern that we may be reducing some elements of patient care in terms of meeting our savings going forward. So I'm just looking for some assurance around that and the impact and what we are doing to look at any unintended consequences moving forward. Thank you.
Yeah, I mean, the quality impact assessment, the work that's being carried out, is really important aspect of that, because obviously we have our finding balance priorities and patient care and our staff, really important aspects of that. So we have, Phil has been developing our work and quality improvement assessment. So impact assessment, sorry. Phil, do you want to comment, please?
Yeah, thanks, Chair. I think you've articulated really well. So I do agree that with internal efficiencies, there's only so far we can go as an organisation. I think what's important is our narrative to be able to demonstrate we've gone as far as we can. I think then the question becomes, what do we do on a regional or subnational level in terms of collaborative working? As the Chair said, we will ensure that every scheme that is put forward will go through our QIA process, which will be overseen by all 3 of our clinical executives. And then, of course, we are engaging with our staff representatives as well to make sure that we do not lose sight of our staff voice and caring for our staff's health and well-being through this process as well.
Thank you. I think Mark was going to say that too, because his hand was up and his hand was down. So thank you for that, Phil. Does that give assurance, Dennis?
It does. Thank you very much. But I needed it to be recorded. Thank you, Phil.
Thank you, Dennis. Laura, did you want to comment on that as well?
Just one addition, because I think Phil and yourself have given a really comprehensive answer. One thing I did want to add is that we are hopefully January time we'll have visibility of the proposed saving schemes across all 3 IJBs, and we've agreed at the Chief Exec team meeting this week that we will get together to go through those, respecting the IJB's governance routes and properly so. But so we've got a rounded picture alongside our own value and sustainability savings schemes for the year ahead. We will look at that alongside the 3 IJB's savings proposals, so we can understand the impact on NHS Grampian in terms of that IJB set of savings. I just wanted you to know that we're taking a much more belt and braces approach, and that session will take place in January. Thank you.
Thank you, Laura. Thank you. Sandy, please.
I just want to come back to the point that both myself and Hussein made, and I'm not entirely in agreement with Dennis saying that we've been assured in relation to reaching the target that we're meant to be reaching. Geraldine touched on some of the detail of what's happening in some parts of the system, and I think I need at the next meeting of PAFIC a little bit more than, yes, we should be fine, we should be getting there, and we've stepped up our monitoring. It is that bit about trying to shift the level of assurance given from kind of retrospective monitoring of spend to being assured that there's active real-time governance that each of the leaders within our organisation have within their sections of NHS Grampian. So it's just getting that reassurance that we're absolutely on it, and there are those processes of grip and control in there, rather than saying, well, actually, we get these monitoring statements and everything seems okay and we should be on target. We need more than that. So, I mean, just that assurance around that different set of lenses that's been applied to make sure that we have the grip and control and it's continuous will be really important for us in terms of assurance.
Yeah, no, I think that's a really important point, Sandy, that we need to know. We can't base our decisions and our assurance on hope. We need to know and have the evidence in front of us of things that are being worked on. And we have got an improved system to the Financial Recovery Board and issues like that than we did have. We know the steps are being taken that way. But Phil, do you want to come in about anything more that can be done along that line?
Well, I think in terms of answering the question on assurance, I think what we can bring through the next PAFIC is almost an audit trail of all the actions that we have taken to strengthen our governance, but what we're also doing on a daily basis and how we can evidence those impacting it. I think there's probably something we can then say in terms of how that gets carried forward into 26, 27 to demonstrate actually the grip and control that we have both at a daily level, but also through our regular meetings and responses to boards continues that into next year. I'm not sure that answers the question, but I think we can definitely evidence the work we have done to date and continue to do.
Yeah, maybe that's us having insight of that as actually maybe it's an important part of the answer. But I'll bring Geraldine in first before I come back to Sandy, because she indicated as well. Geraldine?
Yeah, thanks. It was a similar point. So I suppose it's just about making sure all of the activity is visible in terms of what is happening round about financial control and monitoring at an operational level. So we do have weekly priority meetings now for V&S with all of the senior managers attending, and that has already generated a list of options for savings for the next financial year. That will continue to meet weekly as that develops. And then we also do have, through the new acute sector governance structure, our weekly reports, and that includes details on finance, so in-year savings as well as in-year budget monitoring. So we have a lot of detail. It's just making sure, again, as I say, we can make that visible in terms of just the amount of activity and focus that is on it. Thanks.
Yeah, thank you. And yeah, and the shares assurance reports that we're going to have as well will partly help with this as well, I think. But Sandy, is this giving you the assurance?
Well, yes, but with a plea and a caveat. So I think it's reporting on that changed type of activity that's going to be happening, but we don't want to have a large report on activities and processes. We actually want to hear that activity has actually, kind of refocused and it's now different, but what the impact is and therefore why it justifies the confidence that we will meet our target.
Yeah, the proof of that that confidence is important. Yeah, thank you. I think there's ways here of taking that forward in the new year as well, so we can actually have an improvement on that. Thank you, Richie.
Yeah, thanks. Just one quick update. You'll see the paper references the last Financial Recovery Board. We're going to have a look at Murray's IGB in terms of financial kind of performance. And again, respecting the governance around about IGBs, but we also thought that it'd be helpful to perhaps look across all three IGBs as part of a deep dive. So just to update, I guess, from what's in the paper just now, and I know there'll be work ongoing behind the scenes just to manage that appropriately in terms of the lead through to the next recovery board. My question was actually around on page 124 of the pack, the 4 key financial risks, and just if there's any sense of when we'll know better what the position is with those risks, and if there's any sense of materiality in terms of what that might mean for our budget. I guess the context partly for saying that is also around some of that might then link back to, I think, the earlier points made around performance and sustainability about capacity and such like. So any kind of update around those would be helpful. Thanks.
Yeah, Alex, do you want to come in on those?
Yeah, I mean, I think my view on the risk register is that, you know, we flagged what we feel is the highest risk, and we have done a little bit more work on that in terms of showing what we've been doing to manage that risk within the period. So you can see within the italics some of the changes there, and we've also said whether we've actually going to change the risk or not. We have, for instance, if I take the in-year budget pressures, we have in-year budget pressures that come through every year. You know, even with the best budget planning in the world, it's, you know, we're always going to end up getting some of that sort of stuff coming through, and it's how we manage that. And of course, this year we've managed to manage around about £6 million of in-year cost pressures coming through, and still deliver the £62 million of savings. So we need to manage that. I don't see those risks coming down, would be my thinking on it. I think those risks are probably there, and probably will cut across the financial plan in most of the years. The only one that maybe would be around about the reduced working week, once that's fully embedded and the regradings, etc., are done, then there's maybe something about that one coming off. But that's where my head's at the moment in terms of the risk register. But I'm happy enough to have another look at that if you feel you need more around about that, and because we've also got obviously the strategic risk in relation to finance, which goes into a load of detail around about some of the risk in that space as well.
Richard, do you want to come back? Or?
No, I'm happy that clearly colleagues are aware of it and on it. So I think just keeping us updated as quickly, as reasonably quickly as possible is fine. So I'm content with that. Thanks.
Yeah, maybe the updates could feature more prominently in the finance reports we get as well. The briefings we have on that would maybe be a way of covering those points as well. Thank you. Derek, please.
Thank you. It's tremendously easy to take a negative outlook given the scale of what we're trying to achieve. But I think we need to recognise the savings over the last year and this year, and the savings over next year, are phenomenal. And I think we need to say well done. And given how attempting to achieve savings in previous years has proved not so productive, to achieve what we are achieving, I think is worthy of note. So having said that, the Section 22 report talks about how we're going to achieve more savings, and it says we're going to achieve that through transformation. Now, we talk a lot about transformation, but we have a National Health Service, and I wondered, are we discussing with Scottish Government what transformation would look like in relation to maintaining a National Health Service? In other words, we shouldn't be transforming alone. If something is working for us, it should be working for everybody else. So are we in discussion with the Scottish Government about what the future might look like in terms of what is a National Health Service? Thank you.
Thank you, Derek. I mean, just to come in on that one, I think we have a duty to transform. We have a responsibility for our patients to do transformation ourselves, and together with our partners as well. And I think we're seeing shoots of that at the moment as well, where we are already working across the system. And I think it's important that we do push on our transformation locally and do what we can. And obviously that work on the subnational as well is also an evolving way of doing business, which is really important as well. And the wider aspects is obviously something that's happening elsewhere. So I'll bring Laura in. Thank you.
Yeah, thank you. I think the service renewal framework quite literally sets a framework around the future policy direction, but also transformation ambitions in there. So I think we now need to think about this on 3 levels: the national transformation work, the subnational work, and then our local work. And actually you'll have transformation and redesign in each of those boxes. So the national work we are, Alison, myself, Hugh, June and others are involved in that in various ways, and we'll bring that back into the board in a collective way. The subnational work, as we've touched on throughout various points in this meeting, is just gathering momentum. We know the 4 areas of focus initially, and then the local work, as I've described, we are refreshing and re-standing up the North East Transformation Board. That will be one of the main vehicles through which we choose the service redesign and transformation opportunities looking to the next year. And those terms of reference have just been refreshed. The first meeting will be in January of next year. Thank you.
Yeah, and just to emphasise again, we ourselves have a responsibility in this as well to push it forward and lead on this as well. There's a lot we can do locally on that. Derek, does that help?
Yeah, I mean, I don't disagree at all. There's a lot we can do, and clearly we are achieving. So we need to continue achieving where we can. That's very important. I just bear in the back of my mind that it is a National Health Service, and the Scottish Government did in the past stop us making savings because we were going perhaps a bit too far. So it's just a case of taking Scottish Government with us in terms of our transformation progress. Thank you.
Yeah, thank you, Derek. Hugh, did you want to come in?
Yeah, I was just going to add about the existing feedback loops and how we develop those in the subnational space. So if we think about our current experience with the Government Assurance Board, then within that, the work that we are doing around workforce, and in particular, where we are in our evidencing of compliance with the Healthcare Staffing Act, there's a lot of interest from government colleagues about how that can be generalised to other areas as well. And then in the other direction, particularly around our unscheduled care improvement work, we're getting a lot of support from colleagues in NHS Lothian who've been on a similar journey, but perhaps a few months ahead of us in terms of the timeline. So some of that generalising across NHS Scotland already happens within the structures that we do have. And I think as the subnational structures evolve, and in particular with the shared project management resource across East and West, that will naturally act as another way of ensuring national coordination of those pieces of work as well as subnational. So just wanted to reflect that. Thank you.
Thank you, Hugh. Thank you. Colette, please.
Thanks, Chair. Yeah, I was going to raise this in the next paper, but I think this is probably as good an opportunity as any. It relates to the significant financial risks set out on page 146. And there's been a kind of a discussion about assurance in this paper and in others today. And how do we receive assurance? And my comment's going to relate specifically to the IJBs. And just on that point, I'm a member of the Aberdeenshire IJB. How do we get assurance? We are assured that there are plans in place, there's budget to support it, that there's an understanding of the risk, and then there are controls or mitigation. So that's the process. On page 146, and again in the IJB paper, the controls around the IJB positions are meetings. They're not actions. What comes out of those meetings? What comes out of those meetings is knowledge. How do we deal with that? What actions can we take? I'm fully aware of the governance issues and the separation between NHS Grampian and the various IJBs, but my question is, and I don't know that anyone can answer it today, going forward into the next financial year in the future, is there a way that we can have some level of cross-reporting of the grip and control that's happening in the IJBs that can help provide us with assurance from an NHS Grampian perspective? I know it's challenging, but how can we give assurance today when we are not being given the information on the grip and control that exists elsewhere?
Okay, thank you, Colette. That's a useful question that kind of straddles these two reports. So, Alex, could you answer it in terms of the finance report we've got in front of us, and then maybe we can pick up any other aspects of it in the next paper as well, Alex?
Yeah, I mean, I think that's a good question from Colette. I mean, it is meetings based at the moment. We are starting to pull together that information into one place, as Laura described there in her earlier comment. I would need to go away and have a look at that one, Colette, because I am a little bit concerned that we might kind of step over the boundaries let me go away and have a look at that one just in relation to the how I could frame on it. So I can see the intent, and I think it's a good intent, and I think it's coming from the right place. I just want to make sure that and discuss it with the teams, just to make sure that if I do bring anything back, I'm not kind of stepping into an area that isn't within the spirit of the legislation.
Okay, thank you, Alex. So, Alison, can you note another action then that we will have an update on governance between the finance reports from IJBs to our board as well? We need to follow that through and see what can be done to move beyond the meetings to something else on that one. So thank you for raising it, Colette. We will have that as an action to go forward. Ian, do you want to come in?
Yeah, it strikes me that our council partners might also be quite keen on getting that same feedback, which might make it easier to step very close to the line or even onto the line in terms of what comes back to NHSG.
Yeah, on that basis, Laura and I have got meetings in the diary set up for early next year to talk to the council leadership teams as well about issues like this and how we work forward together. So we've already got those meetings in the diary for January, February time, and that's part of the agenda for those meetings, Ian, to think how we can work together on issues like that. So maybe that's a support as well for what's going forward. So looking forward to seeing you at those meetings, Ian, as well. Thank you. Alex, do you want to come in as well?
Yeah, well, just two bits. I think you might well be right in relation to that, Ian, but I think we need to kind of do that in a kind of partnership type of way, as Alison's described, to get that to land. And just to say, I mean, one of the things that we have done in terms of strengthening some of the governance and some of the information sharing. So at the last Audit and Risk Committee, which was on Tuesday, we did take information on the external audit reports for the IGBs into the system as well. So and we continue to get updates from the internal auditors of the IGBs into the audit and risk space as well. So we are, sharing information both formally and informally, and just trying to make sure those links are as strong as we could possibly get them.
Thank you. And I think with Colette's question, those comments there actually do lead us into moving towards the next paper. So can we close off this paper too? Because I can't see any more indications. On the Finance Report 8.1, we're requested to discuss and note the update on the board's financial position and the current forecast year-end position, and endorse the approach taken to develop the 3-year financial plan and the medium-term financial framework. Can we agree those recommendations, please? Thank you. And then we'll move to the IJB finance report, which obviously is similar to what we've just been talking about. Alex, do you want to introduce this, please?
Yes, this is the second report that we brought forward, and we have tried to put a little bit more detail within the appendices that you'll see, but I'll introduce this report and then I'll ask my chief officer colleagues to come in should there be any detailed questions on their IGBs. But you can see from the report that Aberdeen City is largely living within the level of deficit support provided at the start of the year. Aberdeenshire IGB has improved its position beyond the level of support agreed at the beginning of the financial year, and then the Murray's IGB's position has deteriorated, although actions are now being taken at pace to recover this position. The impact of these changes in the figures flowing through is that we still continue to forecast that we will need to provide £23 million to the IGBs, but should the positions come in as stated within the report, then the £4 million IGB risk provision that's within that £23 million would not be required. And this would effectively reduce our £45 million maximum allowable deficit to £41 million should that be the case. So we're continuing, as I say, to monitor that closely and working closely with the team. I think maybe it goes without saying, but obviously the IGBs are independent bodies established in statute, and whilst they work closely within our system, we need to take care not to direct or make recommendations to the IGBs, and to think about how we do that with our partners if we so decide to do so. So I think this is really here to kind of give you a little bit more assurance around about what's happening within the IGBs, and ask explanations and seek assurance from the chief officers.
Thank you very much, Alex. Dennis, please.
First of all, here, can I just commend Alex and his team for the work and the collaborative nature in working with the IGBs, with the chief finance officers and the chief officers. We have moved on, I think, a long way, maybe in the last year, but certainly in the last few months, in terms of working together and understanding where some of the issues lie. So my question is that Murray was in a position where we felt that we were on target to meet the savings plans that were set down within Murray, and then just more or less left field, an incident took place, which then offset the budget quite significantly. And my question's around really, it's what contingencies can we, and that's probably for every IGB and ourselves within the NHS and our colleagues in the council, what contingencies can we put in place to mitigate these sort of left field things that do come in periodically, as has happened in Murray? It couldn't be forecasted. It was something that happened, that we had no indication that this was going to arise. And it's just, my concern is that we get down to the bone in terms of our savings, etc. But still, I feel that something needs to be there to meet these unintended things that can happen and not forecasted elements that do happen from time to time. And it's just unfortunate it happened in Murray on this occasion. Judith may wish to expand on that and maybe discuss the work that's happening in a collaborative way across the three IGBs. But it was really just to put in context where we were in Murray. Thank you.
Yeah, so how do we strengthen ourselves across the system to deal with the unexpected? Judith, did you want to come in on that?
Well, yes, I mean, just a couple of things to say in terms of the paper, and I think Alex alluded to it slightly. Our handling in Murray and with the budget was slightly different from our partners in City and Shire this year, where their additional contingencies and contributions from partners were front-loaded at the start of the year. We are working on the assumption of support at the end of the year should we overspend, and our overspend position currently is forecast is in excess of those contingencies. So to Dennis's points, there were a number of issues that have led to our Q2 reporting of an overspend, and we escalated this as soon as we were aware of it in Murray to all our partners and to the IGB, and have briefed the board and our board and our partners on that and the actions that we're taking in relation to it. But contingencies were built in by both partners should we overspend. The challenge that we've had this year is the level of pressure that has at this stage exceeded that, and also some slippage in planned savings. We have delivered around about 6.5 million of savings so far, but our target was 9. So it's a combination of slippage in savings, significant service pressures over and above the level that we had contingencies for, and some other issues in relation to things like the employers' national insurance contributions being greater than anticipated. So hopefully that covers the range of things. I think what's really important in terms of how we as a system anticipate this, it's just an ongoing dialogue, an open dialogue with all our partners in relation to our budget position, and that sense that we work with in our tripartite approach of no surprises, and we are in that dialogue very, very regularly with our council and NHS Section 95 officers, just to ensure that we're being really, really clear about where those pressures are emerging. Thanks.
Yeah, thanks. I think that's the important bit moving forward, isn't it? That we have that dialogue and that working together to be able to address that things. Thanks for the question, Dennis. I'll move on to Mark, please. Mark.
No, thank you very much, Chair, and thank you for the report. I think that really provides a lot of insight into the financials of the IJBs and how they interlink with our own. I suppose one of the comments that I would have, maybe Judith touched on that a little bit, of why the differences in reporting about the funding model is different from Murray from the other two IJBs in that they seem to front load their two, then giving you a deficit being slightly different. I just wondered if that was a conscious decision or why that was taken. Excuse me if I'm just misreading this, but I'm not an accountant. I'm more a surgeon than that. So if I'll just stop there. And other thing is, sorry, I won't stop there. I'll say one other thing. I think there is a renewed focus at IJB level at really focusing in on the finances. I think the lack of reserves has really made that happen. I think that's probably where Dennis, having those reserves would have been really very nice for those unintended consequences. Thank you.
Yeah, thank you. Judith, can I bring you in again to respond to Mark?
Yes, I'm not sure that's one for me to answer. I obviously wasn't party to conversations that took place in City or Shire.
Okay, but
so
it's the
maybe
difference
that's
in the
one for Alex.
presentation. It's the difference in the presentation of figures. Then, Alex, do you want to come in on that?
Yeah, I mean, I think that just sort of evolved organically. I think we could, I mean, certainly we could look to try and get some consistency in that going forward. I mean, this was the first time we had kind of agreed a deficit with the joint boards at the beginning of the financial year anyway. So we, you know, we had that and we had built it into our plan. So there's certainly no problems with having a consistent approach going forward, as I see. Obviously, I would only be one part of that conversation, and that conversation would need to be had with the council as well.
That was the bit I was going to add, that's an in-partnership conversation to have on that one, but it's certainly something that I would imagine could be discussed. Thank you. Colette, please.
Thank you. I mean, I raised my main point in the last paper, but I've just got one. I suppose it's an area for discussion. Something that has struck me in my role as a member of the Aberdeenshire IJB is the significant level of uncertainty that the IJBs have around their budget. So at this point in the year, we're waiting for a local government settlement, we're waiting for 3 local authorities to decide their budgets, and they're waiting to hear what NHS Grampian is going to do. And none of that is in their control. They have to wait and see what they're being given. So I welcome the approach we've got at the moment. I welcome the openness of the reporting. I welcome the fact that there's joined up working going on. But as we go into next year and we start to look at the budget going forward, can we make sure that we don't just look at the money? Can we make sure that we look and consider the potential for health inequalities arising if things are not properly funded across Grampian? Because ultimately, if that occurs, that will put a greater burden on NHS Grampian in the future. So it's just a plea really to start looking at this in the round. I appreciate the boundaries there are between local government and NHS Grampian and the Scottish Government, but I think we really do need to focus on the health and social care landscape right across Grampian and do whatever we can to make sure that we're meeting the needs of everyone who lives there. Thank you.
Yeah, I think that overall impact is something that we all share, and the importance of moving to that prevention work as well in order to support health equality across the piece as well is something that's part of all of us. Is again something that will feature in the conversations that Laura and I are having in the new year as well, that working across the system, it's really important to do that. On the uncertainties of budgeting, I think that's a bit of out of our control on that one, that those uncertainties will be there because of the way the system works. But Alex, do you want to come in on anything that Colette raised?
I mean, I think it's a really reasonable ask. I mean, we certainly the work that we're doing in relation to trying to quantify in some sort of consistent form what the impact of any savings will be on people and performance is certainly something that we need to, we're looking and we're working our way through at the moment. I do think you're probably right, Chair. The difficulty at the moment is that we get money, a 1 year kind of settlement coming through, and in relation to the IJBs in particular, it's really dependent on what's included within the settlement letter for both partners in relation to how much money is transferred across. So it's difficult because that can change year on year. So we just need to kind of work our way through that, but I do acknowledge it would be far better for the IJBs to, for instance, have a 3-year financial plan and the funding agreed for 3 years. But I just don't know if that's practical in the current environment and with the information that we're getting.
Yeah, thank you, Laura. Do you want to come in on that as well?
Yeah, absolutely, Claire. I think even with all of the imperfections you've described, I actually do think we're looking at this in the round, both the approach we're taking to integrated financial planning, but we've actually also asked Scottish Government in February if we can have a meeting collectively with all partners, with the Scottish Government, to present the collective picture back in the rounds, as you've described, for health and social care across Grampian, but also to use that as a bit of a, I guess, a position to make some of the cases we wish to make from a financial and funding perspective. So we've gone as far as we can, but I do acknowledge we're operating in an imperfect system at the moment. Thanks, Colette.
Thanks, Laura. And John, please.
Okay, thank you. Just on Colette's point there, the Aberdeenshire IJB met yesterday, and so as the approach was to look at different scenarios, including what the implications are, although it's going to be a work in progress to get the full detail of that. But we're ahead of where we were last year, but there's always going to be that difficulty of finding out the actual amount at the last minute. My question is to Alec, and it's just joining up what's in the previous report on page 123, which looks at 26-27, where there'll be a reduction in the overspend support to IJBs, and then in this report on page 150, just what support has been needed this year. So on page 123, which was a previous report, Alex, it's saying reduce by 9 million into 26-27 the support to the IJB's overspends. Is that reducing it by 9 million or reducing it to 9 million? I'm thinking the former, but just wanted to check.
Yeah, I think one of the things we did through the financial recovery plan, John, was when we had a look at that, we recognised that the provision that we had put in for the IGBs was too high, so we reduced that provision this year. But then in the plan that we had kind of described to the government, we talked about reducing that next financial year as well. So we've got a high level figure in there at the moment in relation to what that means. That would mean, and Sarah will correct me if I'm wrong, but the level of deficit support would be 17 million. That would be shareable across the three IJBs. I don't know. We don't know at the moment whether the IJBs will need that or not. Some may not need any deficit support next year. Some may. We'd need to work through the process to see where we get in relation to it. But certainly, it's a reduction, not a figure.
Okay, that's helpful. It can be challenging either way, but that's more realistic. Thank you.
Thank you. And thank you for all those comments there. And obviously got actions coming forward from that as well, and working with our partners and presenting work beyond meetings to the board as well. Can we turn to the recommendation then? The board is requested to discuss and note the update on the IJB's financial position for the period 25-26. Can we agree that recommendation, please? Thank you. Okay. And now we're moving on to paper 9, the external review improvement plan, developing the governance framework. This is a really important work based on the outcomes of the external review that we had to NHS Grampian. I'm going to turn to Phil, please, to introduce this, please. Phil.
Yeah, thanks, Chair. So as you said, this improvement plan and the governance framework presented is in response to that external review the Scottish Government commissioned in June. That followed NHS Grampian being placed into level 4 escalation of the support intervention framework in May of this year. And then, of course, members will remember that this review was published on the 9th of October. This paper really is the culmination of extensive engagement with operational and clinical colleagues across NHS Grampian, including dedicated time with this board to shape the governance arrangements for how we monitor, report and assure delivery of this plan. It's now here for consideration and approval. I'll just highlight 3 quick points. First, there are 96 recommendations within this report, and we have considered very carefully how these recommendations can be aligned and embedded into our existing governance arrangements. 55, not 54 stated, and apologies for the error there in administration, of these recommendations do align to our 3 programme boards of unscheduled care, planned care and value and sustainability. 32 will sit under our new culture, leadership and governance programme, and those will report through the culture board that has its inaugural meeting tomorrow. And then as members can see in section 2.24 or on page 64 of the pack, there are clear reporting lines through to this board that further strengthen our operational accountability, as well as the committee and board's role in oversight and assurance. Second, in line with the proposed governance arrangements, we have set out in the paper 9 recommendations to be removed from this plan with detailed narrative. The rationale for these is largely due to duplication or amalgamation of similar recommendations, but it is stated within the report. And then finally, just to say that to support the effective reporting, we are currently developing detailed plans for each recommendation, as well as listing the criteria that each must meet to be closed. This work will conclude this side of December, before the end of December, and then as is consistent with presented in this paper, they will be shared with the relevant committees in January. So I'll pause there and then happy to take questions, Chair.
Thank you very much, Phil. Have we got questions or comments about the improvement plan, please, in relation to the external review? Thank you, Mark.
Thanks very much for the paper, and thank you, Chair. Just to say that I'll give my apologies for the inaugural Culture Board, but I only got the invite today, although that was pretty quick coming from Phil, even as we speak. So I'll certainly, hopefully, engage in that from the clinical point of view. And I wish Alex well, in that he does seem to have fairly significant number of objectives that he needs to do in the first priority group. So just a comment. Thank you.
Thank you very much, Mark. Thank you, and good that you'll be on the Culture Board, even if not at the first meeting. Thank you. In the ACF context, obviously. Any other comments, Colette, please?
Yeah, I'm sorry. I realise we're up against time. Just a couple of very minor points on the page number 164. Just a question. The VNS delivery group is meeting monthly, but only reporting the programme board's meeting fortnightly. That looks the wrong way around to me, but it'd be good to have an explanation. What is financial governance under cultural leadership and governance, and how is that different from value and sustainability? I'm sure there's a simple answer to that. And with apologies, Phil, I have read point 6 on page 166 many times, and I can't figure out what that means. So if you could just clarify that for me. I do have others, but I'll go back to Phil separately on those.
Okay. Phil, do you want to take
I think
that Phil will need to look up what that point 6 was, because he won't be able to answer it from his head. So
I think it's just a language issue. I think that's all it is. It just needs clarification, I think.
And sorry, can you remind me of the first question? Oh, it's the programme board, isn't it? So yeah, so I think I can respond to that. So in terms of the monthly delivery group meets monthly because we have weekly meetings with each of the work streams, and therefore we have really good oversight. This is about bringing people together on a monthly basis to see where we're in progress, share success stories, highlight risks, and have broader discussions. The programme board meets fortnightly because we recognise there are some key strategic decisions that need to be made and key pieces of work, and this is about making sure that as an executive team they are closely aligned to the program of work and able to make rapid decisions if things become escalated. In terms of the financial governance, I think what we recognize is that if you look at the cultural leadership and governance, there are a large portion that sit under finance that don't necessarily sit within the culture remit, and therefore what we'll do is we'll just monitor those separately, but those will still feed in through the regular governance framework. So we will still have sight of them, but we just won't have sight of them specifically reporting into one of the boards, but they will all report into CET.
Does that help, Colette?
Yeah, I think I'll email you separately, Phil. There are probably things I'm just not understanding properly from the paper. One of them related to the financial recovery board. It doesn't feature here at all.
Maybe we need to cover that as part of the governance here. How does the Financial Recovery Board fit in, Phil, into what you presented here?
So I suppose it will be there for sharing information, but in terms of its remit, it won't be responsible for holding to account delivery of these recommendations. Those will be through the relevant programme boards up through CET, then up to the relevant committees. I think there's a risk that if we involve too many boards, we actually overcomplicate this. And this is about, we focus on the operational accountability through CET and the programme boards, and then through the board committees and the board, we look at assurance and oversight. I think any more than that, I think there's a risk we overcomplicate this.
Thank you, Colette. Can I bring you back?
I'm really sorry. I know everybody wants a break and get some lunch, but it's the 9 that are being suggested for dropping. Number 5, the proposed replacement for number 5, which is a phased 5% reduction. What's being proposed to change that is very different from the original recommendation. So I was just wondering about how the two relate. I think the solution that's been proposed here is that it relates to agency and locum staff, whereas the original recommendation relates to medical and dental whole-time equivalents. So that's number 5 in the recommendation proposed for removal.
Thanks, Colette. So I think when you look at them in the round in terms of written in the report, the savings related is the totality relate. They all have to go back and look at it. So I thought I had it at my desk and I don't, but when you look at the context of how it's written, they all are specifically aligned within one grouping, and therefore they do relate to the same action. I'm happy to pick up offline.
So I suppose the assurance,
that's fine. Yeah, that's fine. Thank you.
The assurance, Phil, is nothing's being lost by losing those actions. That the issues raised in it are being taken up elsewhere. Is the point, I suppose.
Yes.
And so you can assure us that the original action is not being lost. It's just being picked up somewhere else.
It's exactly that. Yes.
Okay, so that's helpful, I think. I can't see any other. Just what I wanted to just emphasise here, Phil, is in our work so far on finance, we've been very strong about the finding balance work. We've been very strong about mitigating our strategic risks. Just to have confirmation from you that kind of emphasis is still there as these issues move through the programme board. It will be part of that conversation, and we won't lose that finding balance or that strategic risk focus as we move forward. Can you confirm that?
I can absolutely confirm that, and especially for those that relate to financial savings, all of those opportunities are aligned now to one of our 13 work streams in our programme. So each of those schemes will go through the full QIA process.
Yeah, again, I think that's an important point to emphasise here. Thank you. Colette, you can be back.
I'm sorry, I've just scrolled through again. It relates to section 2.3.5 on equality and diversity. This reads that QIA will sit with the clinical executive. Where does the governance of QIA sit? Does it stop at that level, or will it be reviewed at any point by any committee anywhere?
So I think what we've agreed is it will go to the Clinical Governance Committee twice a year. But what we will do is we will produce a report in March when we deliver the plan to board that sets out the full QA process, the recommendations and decisions made by the clinical executive for each scheme, and that will then be presented to clinical governance in March or April.
That's great. Thank you very much and for your patience.
Thank you. And Shatini, you were going to come in there as well. Is that what you want to say as well?
Yeah, no. I think it's been covered. Thanks, Alison.
Thank you very much. Thank you. Okay, thank you for that. I think it was really important to cover those points actually here in the meeting as well. So thank you for that. I can't see any other indications though. So I'll just go through the recommendations then. To approve the proposed governance framework for operational accountability and board oversight and assurance, and confirm the reporting format meets the standard for effective reporting against this plan to engender confidence of the board. We agree? Yeah. Thank you. To reach a decision on whether to remove the 9 recommendations from the improvement plan. Can we agree to remove those 9 recommendations on the basis, as Phil's just said, they're being covered somewhere else? Yeah, we'll agree that. Thank you. So we've agreed that. To note the further work by executive directors to define the evidence base and criteria that each recommendation must meet for closure, and that this information will be reviewed in totality by the chief executive team prior to approval by each respective committee. Thank you. And to note a progress report will be presented to the next board meeting, including a chair's assurance report from each committee, setting out assurance against delivery plans and closure criteria for year 1 recommendations. Can we agree that as well? Okay, thank you very much for that. Thank you. Now we move on to item 10, the IMATA report. Philip, you're presenting this one, please.
No. Thanks so much. So IMATA is the National NHS Scotland Annual Staff Experience Survey, and that's been in place since 2018. And what it does is allows us to understand our staff experience now, compare it to historical time, and also compare it to a national benchmark as well. Overall, since last year, there's been a slight reduction in our staff's experience of working in NHS Grampian, but there's variation across all of the elements of the IMATA survey. So we're performing in line with the national average around 13 of those questions, and they cover some of the core things like access to information, dignity and respect, team function, but we're lower than the national average on 12. and then most significant in organisational and team line manager, including things like visibility and performance management. Within the report, we can pick out some inconsistencies. The most noticeable for me is manager caring about individuals' well-being has stayed level over the years, but the organisation caring about well-being has consistently declined. I think there's a real concern about the reduction in the extent to which members of staff would be happy for a friend or relative to access our services. And I think that just highlights the daily experience of our staff with, for example, non-standard bed spacing, system pressures. So whilst it's maybe disappointing, it's maybe not surprising. But as a consequence of that, reviewing our strategic risk regarding the deterioration of the workforce engagement to reflect that current position, and we'll bring that strategic risk back to Staff Governance Committee. And that will consider what further control measures we might need in relation to that. I just want to highlight within IMATA a really key element is action planning. And the reason why I highlight that is because teams take ownership for the actions that they need to do to improve their own experience. So we've achieved a really significant increase this year in the number of action plans. So it was 58% at the cut-off point for reporting, and it's subsequently increased to 79%. And we're slightly above average in terms of the number of action plans that we have. As a consequence of the IMATA report, we've agreed to focus on 5 key priorities. They've been discussed at, we referred to it earlier in the board meeting at the joint ACF-APF meeting, so I had a really good discussion about it there. It's been agreed at Chief Exec team and it's endorsed by Staff Governance Committee, so it's being brought to the main board for endorsing as well. And those 5 key priority areas are board visibility, listening to staff and staying connected in the front line, prioritising versus the organisational the culture development programme and the culture board, which we've talked about a number of times already in the board meeting, which we're meeting for the first time tomorrow, focusing on leadership development, health and wellbeing, and equality, diversity and inclusion. Looking to ensure that there's transparency of decision making with meaningful staff involvement in decisions that affect them, renewing our focus on annual appraisals and statutory mandatory training, and further strengthen that IMATA action planning cycle, not just to ensure that the actions are identified, but they're actually followed through, so we have meaningful changes. So that's my very quick summary of IMATA. Most importantly, I think, in terms of what the priority actions are for progressing, but I'm happy to take any questions.
Thank you. And yeah, I have referred, we've already mentioned IMATA and the staff experience at various points in this meeting as well, which shows the stress we put on it and how important it is that we do respond to staff experience. And obviously we have this report putting it all together as a global view on that as well. And the point you made, Phil, about the difference between people's experience in a team and people's experience of the organisation is something I think we do need to, as a board, to reflect on a lot as well. So thank you for that. I'll bring in Mark first, please.
Thanks very much, Chair. Thank you, Phil, for the report. And obviously, I welcome the ACF and GAPF joint meeting. I think those have been 2 very robust meetings. The first one was a very honest and open meeting. It's sometimes hard to listen to some of the feedback that comes from our staff, but I think it's really very important that we do. And I think that we've made some real good progress through that already. We've got some good action points coming out of it. And I think our second meeting was already making some very significant progress. So I was very pleased to hear about that. I think one of the things that I commented on previously, not necessarily in this meeting, but others, was in performance management. And I think it's really important that our staff are assured that the performance management is occurring, because I think that's one of the things that IMATA that have been picked up a number of times. So it's just a comment from me. Thank you very much.
Thanks, Mark. Thank you. Dennis, please.
Thank you. I don't think it's particularly surprising in terms of our staff looking at visibility of the board, Phil. I'm just wondering what work is in progress to explain to staff who the board are and what our core function is. And in terms of that sort of visibility, it's something that I just don't think that we've got adequate explanations as to who we are as a board. So it's not really surprising that the staff don't have much confidence in us in some respects. So I'm just wondering what work can be done in respect of that.
Yeah, Dennis, thanks. As you know, there's some work being done already on that in terms of Stuart's taking forward in terms of comms around that. It will be hopefully ready early in the new year to cover some of that point. So there is that being done. Yeah, so we're expecting to see some work on that early in the new year. But Philip, do you want to add anything else on that?
No, thanks so much, Dennis. And I think the work that Alison's referring to is in terms of the non-exec director recruitment that will need to take place. And what we thought would be an ideal opportunity is to signpost potential applicants to what it is that a role of non-exec directors, but also use that to highlight to our existing members of staff as a way of achieving two aims with one thing. And one of those is what the role of the non-execs is, and hopefully increase their visibility as well. So identified an opportunity to achieve two things at once. So as Alison said, yeah, Stuart's leading on that with the comms around that. Thanks so much.
Yeah, thank you.
Very, very much aware of that. However, the board comprises of non-execs and executives, and it's that sort of joining of the board and that who the board are and what are responsibilities are. I just don't think that in terms of the exposure is maybe as good as it could be. And I know we're focusing on the non-execs. However, the board isn't just made up of non-execs.
No, absolutely. And in terms of Laura's leadership, again, she has been leading by example and encouraging all of the exec team to lead by example by being much more visible within the organisation as well, and encouraging all members of the exec team to be much more visible at least 2 days per week. So I think that's also being taken forward.
But it's how you align it to the board. It's fine to say that people are going visits. It's how do you align that experience to the board?
Yeah, thank you, Dan. I mean, I think there are points here about what's actually meant by the board in the iMatter survey. It's another national wording, and it does confuse in many ways. But I think the assurance we can give is the work that's being done through Stuart from the non-exec point of view, for Laura through modelling that visibility. I think between that we can focus on this during the year, so hopefully have an improved figure in response to the iMatter next year as a result of that. So I think we can take assurance that work is being done on both aspects there. So thank you. Kathleen, can I move on to Kathleen, please?
Yeah, thank you. I appreciate this as a sort of, as you said yourself, a global view, and it's really about benchmarking against other boards. From that, there's an assurance there that we're not doing too badly. But I guess where I'm coming from is how much drilling down can you do, and how much do we do to see where there are cultural differences across the organisation, whether it's within different departments or it's within different sites. Because certainly some of the feedback we were getting yesterday at Dr. Gray's is that there is a feeling that there are some cultural issues which hopefully will come forward to the cultural board that's meeting tomorrow. But it's just, how much are we doing, and are we doing follow-ups like pulse surveys when we need to, just to try and make sure that we know what's happening.
No, thanks so much. So there's a couple of points there. So in terms of aggregated up, it is disaggregated. So all members of the executive team have got a detailed breakdown of the iMatter score within their services as well. So that part has very definitely been covered. So apologies if that was missing from the update in terms of the report, but that has been provided. And in terms of how do we measure this going forward, it is on the agenda for our first culture program board tomorrow in terms of what the key metrics will be for all elements of our culture program. So I can assure you that is on very definitely on the list of what our key measures of success will be for that program board, of which employee experience is one.
Thank you. And Catherine's nodding to that, so thank you. And Derek, please.
Thank you very much. Just some feedback, Philip, on my reading and interpretation of the report. The figure 4 year-on-year movement was helpful. It would have been even more helpful had we seen the same for NHS Scotland. I mean, we've got it there for us, but we don't have it there for NHS Scotland. In general, there are very small changes. And I'm not sure how much you can read into changes of 1, 2, or 3 points. Significant numbers of point changes means something's happening, and I think we've seen that with the confidence one. And I don't think that's actually surprising given the scale of the changes that we're having to make, given the financial situation. The other thing that struck me was remarkably consistent right across Scotland. I thought that was remarkable. And with all of these surveys, interpretations of the questions is key. And I was looking at it and was thinking the same as Dennis there. There's a difference between the board and the executive team. The executive team have got management and leadership responsibilities, and then they come into the board with that leadership responsibilities. They are two different things. So when they're talking about the board, did they mean the board or did they mean the management? And I thought it was open to interpretation. So that bit could have been clearer. Now, I know this is national, so it's not ours, but maybe you could perhaps feed that as some sort of comment back on how the thing works.
Yeah, and I think the point from that is that when someone's filling it in, what that's that individual filling in, what are they seeing it as? And that's the bit we will never know what that person thinks. So yeah, there is something there about clarification maybe. But Laura, did you want to come in?
Mine are separate points. Happy to wait, Chair. Thanks.
Okay. Thank you. All right. Thank you, Derek. So yes, there are comments there about clarity that will need to be taken nationally, I think, rather than anything we can do, Derek. Thank you. Anne, do you want to come in?
Yeah, just very quickly. As you know, this week I made a return visit, because something I think it was Stephen said, on board visibility. And every time I've done a visit, they always say it's great to see somebody from the board there. But one of the questions this time I was asked, by a senior member of the team was, why was I there? Why, why did I come to see the laboratories? And I said, well, it was a return visit because I'd been before and I wanted to see what transformation had been made since my last visit. And that actually, he said, that's really good to see you've actually come back and not just seen a visit, done a report, and then that was it. So I think the visibility, and again, I think I have to say to you, Laura, a comment was that they've seen more of the chief executive than they normally would. So that was the comments that I had. But it's really important not only to go, but to go back and make sure that there has been some transformation. But it's always appreciated when some of us are there. So just comment.
Thank you for feeding that back. And I think, as you know, we are updating our management of visits, if you like, if I can call it that, and that's something maybe to think about as well. How we maintain that contact with areas we've seen in the past as well. So thank you for feeding that back, Anne. Laura.
Yeah, thank you. Thanks, Philip. So I just think we need to be a little bit careful when we say these results are not unexpected, because that doesn't mean we should accept them. I actually think they should be cause for concern for us as a board, notwithstanding the challenging year we've had and the landscape in which we're operating at the moment. And I'm really clear as chief executive, if we go into the next year, we really need to redouble our efforts and invest quite heavily in staff engagement and staff experience in a way that this organisation hasn't to date, because these themes absolutely chime for me with the themes that we've been discussing with APF and ACF over the last 3 or 4 months in particular. The culture programme will support with this, and the culture programme board will be central to overseeing this work, but we've got to put staff experience and staff engagement front and centre of absolutely everything we do, because actually if we do not do that, the performance won't follow. And I think we all risk missing the point, if I might be so blunt to say that. So we have to invest in this and do it in the right way and have proper programme around staff experience and engagement and culture in a way we haven't before as an organisation. I fully support the 5 priority areas and the organisational focus, as well as the action planning that's happening at local level. But we need to move beyond asking for feedback and completing action plans to actually following it through and listening and doing something about it. And that's the bit that's missing for me, both locally and organisationally at the moment. And we need to hold ourselves to account for that. So I think the 5 priorities here are crystal clear. I fully support them. I know they were discussed in full Staff Governance Committee last week, but we need to lock these into our priorities for 26-27 and have clear metrics so we track our progress in a really quite forensic way. Thank you.
Yeah, thank you. I think that came out in our performance report as well, how we do report on the operational improvement plan and performance, how important staff contribution is and how we need to support staff wellbeing and listen to what's being said to us across the piece as well. It came out earlier in today and it's re-emphasised here. Obviously got the programme board meeting tomorrow, which is a start, but I think the other point is that we all have a responsibility here, each one of us around the table, execs and non-execs, to actually support this work going forward as well. And Joyce, as staff governance, do you want to come in on that point?
Yeah, I mean, I think this is absolutely critical, and it's something that staff governance has been speaking about for a number of years, and we've seen the areas where there has been proper engagement, when the work with Magnet has been done, where there's real engagement, real listening, and real improvement. And then we see with many other areas where somebody goes in, asks a few questions, gets a few views, then goes away and something's decided, and then it happens again. And again and again, and Dr. Gray's is one of those areas, particularly where, you know, how many reports and reviews have been done on that, and it's still the same issues that come up. So I think it's absolutely vital that we engage in a different way. We really listen to staff, and if we can't do what we want, we tell them why and try and explain things, because we can't always do everything that everybody wants. But by explaining it, people have a better understanding, because they may not have understood why in the past. I think this is probably one of the most important pieces of work that we do, and certainly staff governance is fully behind it.
Yeah, I think the key is working with, isn't it? We all need to work together. Working with people is key on that one. Thanks, Joyce, for that, and thanks for the work of staff governance around this as well. Kathleen, do you want to come back?
Yeah, please. It's really just to endorse everything Laura and Joyce has just said. The key line I got out of the visit yesterday to Dr. Gray's was that the staff sometimes do not feel they're on the journey with us. And I think that was really telling. And I think that is the bit of work that we need to do, that they need to feel that they're part of the team and that they're on the journey. And that I think that was a very telling comment. So it was just to endorse what Joyce and Laura have said.
Yeah. Working with, being on that journey together is really key, and I think we've made starts to that as well with those joint ACF and APF meetings, and those other things we can all do. And again, I'll just emphasise that point that this is something we all need to work on, and we all need to be part of this journey and be active on it as well. So thank you. Okay, I can't see any other comments on that one. So we turn to the recommendations to review and scrutinise the information provided and confirm it provides assurance that policies and processes are in place and robust, and endorse the priorities for improving future staff experience. Can we agree those recommendations, please? Okay, thank you. Okay, then we turn to the approved committee forum and IJB reports. We need to run through these for noting. Can you indicate if you want to comment on any of them as we go forward? Clinical Governance Committee, 19th of August 25. Noted. NHS Grampian Charity Committee, 2nd of June 25. Noted. Performance Assurance Finance and Infrastructure Committee, 3rd of September 25. Noted. Population Health Committee, 26th of September 25. Noted. Staff Governance Committee, 28th of August 25. Noted. Area Clinical Forum, 3rd of September 25. Noted. Grampian Area Partnership Forum, 1st of all, 5th of August 25. Noted. 21st of August 25. Noted. 16th of October 25. Noted. IJBs, Aberdeen City, 30th September 25. Noted. Aberdeenshire IJB, 3rd of September 25. Noted. Murray IJB, 25th of September 25. Noted. That's all of them noted. I've got no any other business notified to me. And date of next meeting is the 19th of February. Ian, sorry.
Thanks, Alison. Without further extending the length of the meeting, I've just wondered, given that we've overran for very good reasons by about an hour on our original scheduled time, whether there would be any merit in considering in future making these the appointments for these meetings, not necessarily the meetings, a little longer, so that people who have full diaries aren't having to leave at 1:05 or 5 to 1 because they've got something else they need to be doing because this meeting has been scheduled to finish at 1 p.m.
Yeah.
I'm not suggesting we'll go on for longer, but there may be times when we do.
I've been reflected on exactly the same thing. I think the agenda time, the meeting times were set up when we had far fewer things on the agenda. We're now looking at the the delivery and the East connection as well, and things like that, that are new on our agenda that we haven't had before. So we are needing to cover more items internally and externally as well. And we haven't had the IJBs featuring our agendas in the past as we do now. So there are lots of things added to it. So I think the realism is that we need to make the appointments longer because we have more agenda items for all the right reasons, but we need to do that. So I take that point, and that thought was actually going through my head exactly the same as well, Ian. So thank you for that. With that, the date of the next meeting, which will be longer than it is currently in the diaries, is the 19th of February 2025. Thank you for that. And thank you for everyone's interest in the meeting. Can I just, before board members, before you depart, we have a closed board meeting this afternoon. Would you like to take a small comfort break before we start that one, or a proper lunch break before we start that one? Could I take any soundings on that? In other words, do you want to start at 2:45, or do you want to start at 2:30?
Short break will do me, Chair.
Derek?
Yeah, I've got a hard deadline of 2:45. I must be away by 2:45.
All right, shall we start? We will have a short break then, and we will start. Sorry, Ian, you're going to come back?
Short break's fine as long as you don't mind watching me eat the last of my lunch when we reconvene.
All right. No. All right, we'll come back at 2:15 then for the closed board meeting. Thank you, and thank you everyone for their interest in the meeting. Thank you.